I will be serving as your chair only for the briefest of moments this morning. Since I have a kiddo home from school this morning, I have asked our Vice Chair, Siobhan, to facilitate the remainder of the meeting this morning. So after roll call, I will hand it off to Siobhan. Let's go ahead and take roll and we'll see if everybody's had a chance to join this morning. Thanks for your participation. Siobhan Martin, are you here today? I think I see you. Yes.
Yes, I'm here.
Greg Clauser, are you here this morning?
Yep. Hello.
Good morning, Greg. Sean Parkman, are you here this morning?
I'm here. Morning.
Good morning, Sean. Emily Wong, are you able to be with us?
Yes, I'm here.
Good morning, Emily.
Good morning.
Rep Nose, are you with us this morning?
Yes, I am.
Thanks for joining this morning, Rep Nose. All right. I have as excused Cheeky Flowers, Andrea Foltz, and actually Kimberly Hendricks.
But I'm
and
here.
I see you, Kimberly. Hello. Andrea Foltz, are you here? Or Cheeky Flowers? Both excused. Okay. Excellent. Thanks so much, everybody. I'll go ahead and hand it off to Siobhan. Thanks for your grace. I'll participate in the meeting. I just won't facilitate so that I can potentially be responsive to my kiddo here. Thank you.
Thanks, Dawn. Good morning, everyone. I'm Siobhan Martin, and I'm the Vice Chair of the PEB Board. And we are now going to take approval for the minutes from our August meeting. So do I have anyone who has a motion to approve the minutes? Have folks had a chance to look at them?
This is Greg Clauser. If no one has any amendments, I'll make a motion that we approve them as written.
All right, thanks, Greg. Do I have a second?
This is Sean, second.
All right, thanks, Sean. And Kimberly, how do you vote?
Sorry, I had to find the mute. I approve.
All right, thanks. Emily, how about you? How do you vote?
Approve.
All right, and Dawn, how do you vote?
Approve.
All right, and we had Greg as the first and Sean as the second, so it's unanimous, and our minutes are approved from August. Thanks, everyone. And before I hand it over to Mercer, I just want to make sure that everyone is aware that as we enter a process on the PEB board, the RFP process, or request for proposal process, these presentations and discussions are to facilitate the knowledge and discussion between staff, Mercer, and the PEB board. And so we need to make sure that we have to maintain the integrity of the RFP process. And so we are asking that any potential proposers that will be putting in a request for proposal for PEB to refrain from questions and comments during the presentations. So comments can be submitted when responding to the RFP process. And we just don't want anything to impact the integrity of that process. So that's why we're sharing that with all of you today. So appreciate your cooperation and understanding, as this is going to be a lengthy process for everyone. All right, so I believe we've got Mercer, who's going to be leading on the first presentation. Is it Sarah that I'm handing it over to? Sarah Drake, is that right?
It will be Sarah. I was going to do an intro, but thank you, Siobhan,
Sure,
Vice Chair,
Amory,
for
go ahead.
actually presenting that slide. Where yes, this is going to be part of our overall discussions over the next few months to discuss the RFP process. And these are to help the board understand and to help shape the RFP process. And as Sean mentioned, we are dedicated to transparent process, but we want to be fair to everybody. So please do I guess, follow the instructions and hopefully refrain from comments, at least during this immediate process before the RFP it has been released. But this next presentation's on pharmacy. Pharmacy tends to be more of a standalone, but it is coordinated and a big part of the overall PEB plans. And so there's going to be a lot of information that Sarah Drake's going to be providing, some of its background, but some of it will also hopefully provoke some thoughts and potentially some direction for where we want to go with the PEB pharmacy programs. Pharmacy does make up 15 to 20% of your overall cost, so there could be some potential good savings to help meet the 3.4% threshold. But there's a lot, like I said, there's a lot of information here that Sarah's going to provide, and then the additional presentations from the plans will also help inform you as we move forward in this RFP process. But with that, I think I'll turn it over to you, Sarah.
Yeah, thanks, Emery. So as you'll see on the screen, what the agenda is for today, for my section of the presentation anyway, we'll talk through your current pharmacy structure. So how are your pharmacy benefits currently structured with your carriers? We'll talk about what we're seeing in your data as far as the pharmacy growth trends and what's really driving those growth trends over the last year. Then we'll talk a little bit about what we're seeing overall in the landscape of pharmacy benefits. There's been a lot of discussion about pharmacy benefits in the news and the media. You may have seen some of that. We can talk through some of that too. And then we'll go into a section around RFP planning and talk about what are some of the different levers that you can pull in order to manage your pharmacy benefits, some of which you could do outside of an RFP process, but some of them might be best in an RFP process. I am not scripted today, so I want this to be interactive, so please interrupt me as you have questions, and let's have a good discussion for the next hour or so. Let's get started with the first slide and talk about where are we today. So as you know, today you have 3 carriers in PEB, MODA, Providence, and Kaiser. And what you can see over here on the leftmost column are some of kind of the different configurations that you might see in pharmacy. And we'll talk through each of these in depth when we get into the RFP structure, but I wanted you to see where are you today. So as far as structure with MODA and Providence, they're both carved in to the medical plan. So that means that the pharmacy benefit is managed by the medical carrier. With Kaiser, you have a fully insured both medical and pharmacy plan that's all together. As far as formulary, with MODA, you have what they call the MODA High Performance Formulary, which I don't believe is the most aggressive formulary they offer, but it does have a formulary that has exclusions, meaning not all drugs in the universe are included in the formulary. When MODA gives their presentation later, they can likely talk a little bit more about how they manage their formulary and their pharmacy benefits. Providence is similar. They have a formulary. It's called the Providence Formulary D. And again, that is a formulary that has exclusions. Not everything in the universe is covered, but I don't believe it is their most aggressive formulary. And then Kaiser has their integrative program formulary. As far as the network, both MODA and Providence offer a broad pharmacy network. That means most pharmacies in the community are going to be included in the network. They offer mail order through both PPS and Costco. There's not a requirement for members to use mail order, but it is an option, and there is a small copay incentive where they can get a larger day supply for a lower copay if they do go through mail order. There's also an option for them to get for members to receive 90-day supply through what's called many preferred chain and independent pharmacies. And in both the MODA and the Providence case, these are pretty broad networks too, meaning that there's a lot of variety for members to go to pharmacies. They're not required to just go to one particular or 2 particular pharmacy chains. With Kaiser, it's a limited network. They're an HMO. It's the Kaiser pharmacies only. As far as specialty, all 3 of the vendors currently have exclusive specialty pharmacy relationships. And that means that members who are using specialty drugs are required to go through one particular specialty pharmacy. So with MODA, theirs is exclusive through Arden, Providence is through Credina, and Kaiser's is, of course, through Kaiser. There's always exceptions. There are certain drugs that are only available through very limited distribution networks. If that's the case, there's an exception. But by and large, most members using specialty drugs are required to go through these specific specialty pharmacies. And then as far as their financial model, so the MODA contract is structured as pass through, which means what is paid to the pharmacy is also what is charged back to PEBB. And they have discount and rebate guarantees, meaning that they're guaranteeing a discount off of a price. And then there's a guarantee on rebates. Providence also has pass through, but they're doing it with a trend guarantee, meaning that they're guaranteeing some level of trend. I saw a comment come through on Teams and someone corrected me, which I greatly appreciate. Katie clarified that the MODA high performance formulary actually is the most aggressive formulary that's offered by MODA today. Thank you, Katie.
Yes, thank you.
Okay, and then Kaiser is a fully insured model. So the PMPM premiums to Kaiser, that includes pharmacy. There are no rebates passed through. Any questions on the current structure before we continue on and talk a little bit about what we're seeing in data?
So I had looked through the slide deck previously, and maybe we'll dive more into this. So what I'm curious about is the structure of the transparency piece. Like, how do we see whether we're getting the best prices, whether that's, the way that it's set up through Ardon or through Credina, I don't know how to say it. And maybe you'll talk more about that later, because I know there's some slides on the pharmacy benefit managers and transparency. So I just wanted to put that out there. But for me, it's hard for me to get my head around, like, oh, are we getting the best prices here? How do we see that?
Yeah, I think that's a good point, and that is a challenge. Just because what you're paying is the exact same as what's being paid to the specialty pharmacy, is that the best price in the market for that particular prescription? Maybe, maybe not. For the most part, these contracts are negotiated on an aggregate basis. And so the goal is always to make sure that you're getting the best price in aggregate across all of the prescriptions. And so when we review offers as part of the RFP process, what we'll do is we'll take all of your utilization, trend it forward, look at the offers that we receive in aggregate from each of the carriers, and then model it out. What would each of these offers look like given your current utilization? And then you'll be able to see a comparison. But you're right, on any given drug, it may or may not be the best price in the market. It's all done in the aggregate. And that's one of the challenges.
Okay,
Yeah, I
thank
see
you.
another hand up, Mr. Judge.
Yes, this is Robert Judge from Moda Health. I oversee the ArrayRx program that is used by PEBB, and related to the transparency and the pass-through. PEBB and Mercer have available.
Sorry. I'm gonna have to step in here. Sorry. This is the type of conversation from the vendors. Unless you're correcting an actual issue, please do not comment on stuff like this as we're going through the presentation. We're trying to be fair to everybody, and experts, I know you're online, but please do not step in and try to show your expertise during these RFP presentations. It does potentially bring up potential favoritism in this case, and we want to be fair. I don't know if I can be stronger on the warning, but we need to maintain integrity.
Emory, I appreciate the point.
Okay. And to Emery's point too, and I very much appreciate him being bad cop here, because it is important. We want the integrity of the process. But if I do say something wrong and you need to correct me, just like Katie did, please do. We want to get our facts right. Okay, let's move on to the next section, and let's talk a little bit about what we're seeing in your data. And so what you can see on this slide, and we looked at this last November too. I updated, you saw the same slide, and I updated it with the most recent data. And so what this shows is the most recent year that we had available. So this is from May of 2023 through April of 2024. We looked across all of your carriers and looked at the pharmacy data. Now, this is pre-rebate. It doesn't include any rebates. This is how much was paid out before rebate. But what's interesting here is there's just 3 categories that are making up 62% of your pharmacy spend. And those are immunosuppressants, which includes drugs like Humira, some of those other specialty drugs you maybe see on TV like Skyrizi, Taltz. It includes diabetes drugs and supplies, which includes not only insulin, but also GLP-1 drugs like Ozempic, SGLT2 drugs like Jardiance, and all other diabetes medications. Molecular targeted therapies, we'll see a little bit more about those, but those tend to be specialized medications used for rare conditions. But those 3 categories are 62%. And when you're looking at the trend for those 3 categories, they're growing rapidly. So immunosuppressants is growing 11%, and that's actually down from what it was growing previously. The reason for that is, one of the reasons for that is that there's a biosimilar now for Humira, which was the top drug in that category. That became available in late 2023. And you'll hear from some of the carriers on what they're doing in terms of biosimilar strategy. So you can hear what they're doing to help bring that trend down on immunosuppressants. Diabetes drugs and supplies. Yeah, go ahead.
Just from my understanding, so immunosuppressants, I understand have pretty wide use. One of the uses is any kind of autoimmune, disorder or that sort of thing. Is that kind of the main area of use at this point, or am I? In other words, it's not something that's influenced by behavior change or anything like that. It's just sort of like a condition. Is that right?
Yes, that's a good question. There's a lot of different conditions that are treated by these drugs. They include things like rheumatoid arthritis, Crohn's disease, inflammatory bowel disease, psoriasis is another one. There's other medications that are not biologics. They're called DMARDs that we used to see used more frequently first line. I think what we've seen over the last decade or so is a change in clinical practice where people are using biologics earlier in therapy rather than later in therapy. Something like psoriasis, we maybe used to see more light therapy, whereas now we see more biologics. So it's not like diabetes type 2 where, sometimes there's lifestyle interventions. It's a little different than that, if that answers your question.
Yeah, it does. And I appreciate the little sidetrack here. I don't want to take too much time. We talked a lot about diabetes in general. So that feels fairly clear. Immunosuppressants I know are expensive, and I guess a little bit of what I was probing about is like, is this the conditions essentially increasing? Is there an increasing what am I saying? Like disease burden in the population, or is it more like more conditions are being found to be effectively treated by immunosuppressants, or at least partially, or neither? It's just the price is just high.
I think it's all of the above.
Yeah.
Yeah.
I think that there's some understanding of some disease processes as being autoimmune that were 10 years ago maybe not understood in that disease model. But I will say, I mean, some of the outcomes of earlier pivot to this drug class has to do with the effectiveness of the drug and the impact on the individual in terms of their, like with rheumatoid arthritis and some other things, their functional capacity. Certainly with MS, the functional capacity of the individual on this drug regimen is much better. So I think, and then Sarah can take responsibility for the price.
Yeah, Sarah, what's going on? No, that answers my question. I appreciate the quick little diversion here. Just curious.
Sure. Thanks.
Yeah. No, it's a good question. And the price is not just, there's an element of price of existing drugs continues to go up as the manufacturers take increases every year. But the other thing that's going on is that there's newer drugs that are, bring maybe easier administration or less frequent dosing or some other incremental improvement. And then every time there's a new drug that comes out, the price goes up. And then as people are using more of the newer drugs rather than the older drugs, that's a price element too. So I think that's also something interested to hear when our carriers present their biosimilar strategies on Humira. We want to hear about, what's going on in that space. We've seen a lot of the newer drugs like Skyrizi, Taltz, Tremfya that are on TV. What is being done to ensure that those are maybe reserved for later in therapy if there is a biosimilar available at a lower cost now. Okay, let's go to the next slide and dig down a little bit more and look at these top categories that are contributing to trend growth. So these 7 categories are accounting for most of the year-over-year prescription trend growth. So if you look at these 7 categories in aggregate, the year-over-year change is 19%, whereas all categories total is 14%. So there's some categories that are going down, of course, so that are offsetting. So a couple here we wanted to call out, of course, diabetes, immunosuppressants, we talked about those already. That CNS miscellaneous category, there's a couple things going on there. There's a newer drug for ALS that they cost over $15,000 per prescription. So that's part of what's going on there. And then there's also a product called Daybue, which is for Rett syndrome. The PEBB program has 2 utilizers with that very rare disease. And just those 2 utilizers, it costs over $500,000. So it's just a really expensive therapy. And then the other drug that's in there that's contributing a lot to the growth is Nurtec, and that's a newer drug for migraine that's seeing a lot of utilization growth. Vaccines, there's a big growth in vaccines here. I don't know that this is an increase in people receiving vaccines, but what we saw between the previous period and this period is the COVID vaccines now are no longer free from the federal government. And so there's a cost associated with those. That's part of what's going on here. And also there's new vaccines for RSV for the first time, and that's contributing as well. Miscellaneous therapeutics, just a couple to call out there. Trikafta is a drug for cystic fibrosis. It costs about $300,000 a year. Galafold, there's 1 patient that's over $300,000. And then down under antivirals, Paxlovid, which of course is for COVID, that used to be available for free from the federal government. Now that the spend on that in the last period was about $500,000. Let's go to the next slide, and I wanted to show a little bit. So this is pretty interesting. I wanted to show by carrier, and of course, part of this has to do with, what membership might be in what carriers, and you can get some of these very high cost members like the people with Rett syndrome in one carrier, and that can skew. But I really wanted to highlight how there can be different strategies in pharmacy, and different strategies can be successful. So on the top, this is pharmacy growth by carrier. You can see all carriers total. We had 11% year-over-year change. Providence at 14%, Moda at 8%, and Kaiser at 3% on plan spend. But when we look net of rebates, so once rebates come in, and currently we don't get the rebates at the drug level available, we just get the total rebates reported from the carriers. Kaiser operates without a rebate model, so theirs is the same. They've got 3% growth year over year. But when you look at the offset of rebates, it makes a very large difference in what we're seeing year over year. So for example, Providence went from 14% year over year to change. Once we put in the rebates, it was only 7% year over year change. Moda, we saw an even greater improvement where it went from 8% to actually a savings of 12% year over year. And we attribute that to some improvement in the rebate contracts that Moda was able to negotiate through their coalition. Let's go to the next slide. Oh, okay. Let's go back real quick. Just any questions on this before we go on? Again, we can see success in different models. So sometimes we hear it needs to be a rebate model or it needs to be no rebate. I think we can see success both ways. That was my point in showing this.
Yeah, and I just wanted to make sure I was following. So Kaiser doesn't do that strategy, right? And so,
Correct.
they've been flat. And we were looking at a couple meetings ago whether rebates work or whether they don't. I know we were having that discussion, so it's clearly a very open discussion about what works and what doesn't. Okay. Thanks.
You bet. Okay, one of the other things we wanted to look at, let's go to the next slide. So this is a bouncer assessment, and we've done this at Mercer for a number of our clients. What this is you think about, we call it bouncer because it's like you're at a club, there's a bunch of expensive drugs out trying to get into your plan, and how effective is the plan in terms of being a bouncer and keeping those what we call high cost, low value drugs out of the plan. So sometimes this can be something like there's an extended release version of an existing drug, or it's a capsule rather than a tablet, and it costs 10 times as much. So what are the plans doing to keep some of these low value products out? So let's go to the next slide. So this is what we're looking at, not wanting to hit the plan. You can see on the clipboard there, those are all of the different categories that we're looking at. And I'm happy to take questions about what each of those are, but just in the essence of time, we'll move on until we get questions. But what I want you to know, we start with thousands of drug codes, and these are drugs that have been identified by our team as they're high cost, low value. We have about 5,000 troublemaker product codes, and then we bump up the utilization of the carriers against those codes to identify how much of the spend is these quote unquote troublemaker drugs. We did this analysis for Moda and Providence. We did not do it for Kaiser because Kaiser is a fully insured plan. So it's not like those costs are passed on, you pay a premium. So let's go to the next slide and you can see, there's the bouncer. That's my favorite graphic ever. I wish I would have created it, but I didn't. So when we looked at the Moda plan, what we found, out of the full spend of 37.3 million, we found under $100,000 in potential savings for these bouncer drugs. This is really good news, actually. I've done these for other clients and seen upwards of 3%, 4% of spend that is these bouncer drugs. So it's really great to see for both of the carriers that the spend was under 1%. The largest opportunities that we saw were around these drugs we call rebate chasers. And the largest opportunities were some of these newer antidepressants that have been marketed at a very high price and they have a high rebate. Also seeing some overpriced versions. And the top ones there, sorry, I've got to pull my notes here because I forgot to memorize it. The overpriced versions tend to be drugs like high cost versions of extended release metformin, something that might cost over $250 a claim when there's a $10 version available, or some very high cost oral contraceptives that might cost over $400 a claim when there's similar products containing the same active ingredients that cost under $10. And then the other category that you see opportunity for is what we call copycat drugs, and that where there's minor modifications to existing drugs that allow it to be marketed separately at a higher price tag. And so what we see there is something like newer versions of methylphenidate, which is the same drug that's in Ritalin, that are marketed at a really high price tag. Or there's some eye drops for dry eye that can cost hundreds of dollars per prescription, and that's kind of what's fitting in there. When we're done, I'm happy to share the list of some of these drugs that we found or some of the top drivers with the carriers if they want to take a look at their formularies and see where there might be opportunity to improve.
But even including those categories, you're saying we're still talking about less than $100,000.
Yeah.
Okay.
Yeah, that was good. And again, this is good news. We do this for plan hygiene. And yeah, seeing this at under 1% overall says that your existing carriers are doing a good job at identifying some of these drugs. It's always room for improvement. But overall, they're doing a good job identifying some of these wasteful products. If we look at Providence, we saw similar results there. So they have larger spend to start with, right? About almost 150 million. Estimated savings potential about $500,000 or 0.4%. Again, good news. This is under 1%. We were pleased to see this. But, you know, still just order of magnitude, it's such a large plan, even if you're making some surgical adjustments, there can be opportunity for savings there.
Thanks for that. And did you say you would be sharing with the plans? I would imagine they would want to
Yeah,
see.
we can give them a list of what some of the top drivers are so that they can take a look at their formularies and how they're managing.
That's a good
Okay.
analysis. I appreciate it.
Okay, so let's move on. I'm doing a time check here, half hour in. So let's talk a little bit about what's going on in the pharmacy benefit landscape, and then we'll talk about what we want to look for in the RFP. So these 7 things that you see up on the screen in the bubbles, when we think about what's going on with pharmacy benefits over the next 2 to 3 years, these are the things that we're seeing really affect the pharmacy benefit and what's affecting the landscape. So of course, obesity as a chronic disease, we've talked a lot about the growth of GLP-1s, both for diabetes, the continued challenge of the cost for GLP-1s. We definitely know that PEB is interested in finding a way to cover those in the future. And some of that means, you know, maybe finding savings through this RFP process. Another thing we're talking a lot about is that it's a mouthful, challenging vendor exclusivity and RX disruptors. What does that mean? I'll talk a little bit more about that on the next slide, but big picture, historically, we've seen maybe just 3 pharmacy benefit managers control the vast majority of the pharmacy market. We're seeing a lot of newer vendors come into the space with, you know, newer models for transparency, newer models for pricing. We're seeing disruptors like Mark Cuban, Cost Plus, Amazon Pharmacy coming in trying to shake up the pharmacy market and, you know, offer individual patients better pricing through improved technology. So that's what we mean there. Regulatory requirements, we're seeing both at the federal level and the state level, a lot of activity around pharmacy. There's a bill, for example, that was just passed at your neighbors in California. Senate Bill 966 passed both the House and the Senate. We're waiting to see whether or not Governor Newsom signs it or vetoes it. But what that bill would do is it would limit any steerage to specific pharmacies, so that, for example, you couldn't have a network where members would be required to go to a certain pharmacy or required to do mail order. And so those kind of bills are coming, I think, largely from the independent pharmacy community, but it's something to be aware of in that it could affect what your flexibility is around your benefit moving forward. Also seen things in states around requirements for how much plans need to pay dispensing fees to pharmacies, especially independent pharmacies. That kind of thing has passed in some states. So we're just seeing a lot of legislation that could have the effect of limiting what can be done in the pharmacy benefit space. I see Representative has his hand up.
Yep. I just wanted to let folks on the PEB board know that some of the things that you just mentioned in the state of California are also being contemplated here in Oregon.
I figured as much, so thank you for verifying.
I'm running a PBM work group, so they're being contemplated by yours truly.
So, you know, this is definitely something to keep in mind.
And then I think we have Emily and then Sean.
Yeah, thanks. This is really helpful. I'm just curious about the possible merger between Albertsons and Kroger that's been in the news lately, and how that might impact or not impact access to pharmacies in Oregon. I'm learning about the pharmacy desert terminology and just wondering if there is a map of existing pharmacy deserts in Oregon, or like if a merger like this happens, how that would impact access.
Yeah, that's a good question. I'm not aware of a pharmacy desert map, but something that we could certainly do as part of the RFP process and we would recommend is doing geo access. So any any bidders that are responding to your pharmacy RFP would need to provide information on how far away any member, given their zip code, would be from a pharmacy. So you could identify if there's any deserts or any holes in the network. As to your specific question, I don't have a good answer to, I don't know what would happen with the Albertsons and Kroger merger, but I can tell you that not all of the major PBMs do contract with Kroger at this time. So if there is more, if there's more Kroger in that space and there continues to be a dispute between Kroger and one of the major pharmacy benefit managers, that's not one of the PBMs that's currently serving PEB. But that would be something to keep in mind. Again, as part of the RFP process, you would want to understand what the network is and probably want Kroger to be included if that is a provider that's serving people in more rural areas in Oregon.
And Ollie, did you want to respond to Emily?
Yeah, I just wanted to let Emily know, thanks Siobhan, that OHA is doing a review of the Kroger Albertsons merger and looking at things such as access to care and impacts that merger. And this has actually been a several month process. So hopefully we'll have a resolution to that in the next month or two. But I just wanted to jump in and let Emily know about that. Thanks.
Oh, thank you. That's great to hear. Thanks.
And then Sean, I know you had your hand up too.
Yeah, a couple of quick questions. So first, on the issue of a legislation scan, I always appreciate Mercer's, expertise, just kind of being aware of what's happening. Not for today, because that's not the point, but related to this slide, I think it would be helpful to have a little legislative scan of other states, just to really look at what are the not so helpful legislation things that we just kind of need to be aware of that are happening, but also things that other states are experimenting with that might actually be helpful legislation for the purposes of containing costs. I know that we've circled around that issue a couple times, and PEB kind of has this unique, NOEB has this kind of unique opportunity and relationship with the legislature, because we're, sometimes an experiment place for them, which can be a good partnership sometimes. So that might be a useful conversation. Just be like, are there any states who have tried something legislatively that have actually potentially been helpful? So there's that. That's just a comment. We don't need to do that today because that's a different thing. It is more relevant for today is, are you aware of any plans sort of nationwide? And I'm just talking like in general here. I don't need any call outs on a specific plan or something, but I'm just like, is it a thing that any plans have experimented with plan design where there's any kind of price connection or mail order dynamic that somehow relates to Canada, like Canadian prices somehow? I'm assuming the answer is no, because there's probably rules against that, which is why no one does it. But it's like these are the same companies selling the same drugs, and of course Canada's pharmaceutical costs are like whatever it is, like at least half the costs in the US. So I'm just curious, like, are there any examples of plans anywhere that have done something about that? I don't know what it would look like, but some kind of connection with price comparison or purchasing or something with a Canadian connection. Just checking.
Yeah, so I think the easy answer is probably no, but it's more nuanced than that. The FDA released some new guidance on importation a couple of years ago, and Florida has been looking at importation. I think not necessarily Canada, but Canada among other countries is focused on their Medicaid program at this point. but it sounds like they might expand to public employees at some point in the future. So that's not necessarily reference-based pricing, which I hear you're saying, like tying the price of American drugs to Canadian drugs. That would likely need to be done at the federal level. But what they're doing is a process to actually import drugs from Canada. So that is out there. Representative, you might have maybe you
Yeah.
have an example.
We looked at it for a hot minute here, and I think we concluded that we would let other states try. I think folks have to remember there's only 31 million Canadians, and their country might have some opinion about their drug supply suddenly being the supplier for the United States.
That's a very real concern. There's not enough drugs in Canada to serve even the people in Florida, much less the country.
I think this is an interesting quixotic thing that other states are trying. We should watch what they do, but I don't think that's a thing.
Okay, but it is an interesting topic for sure. And we can take back the ask on looking at different legislative activity in other states as a future presentation. That's a good suggestion. Other things that are shaping pharmacy, we've seen some activity around prices. Models the beginning of this year, the price for some of the top insulins actually came down on a sticker basis. So that was kind of an interesting phenomenon. And then at the same time, we're seeing new pricing models related to that. One thing we don't know yet is what is going to be the impact of the Inflation Reduction Act and some of the Medicare price negotiation. Even though the Medicare price negotiation only applies to Medicare, it's possible that there could be some spillover effects, either in a positive way or a negative way, to the private employer market. And that's something we're really watching. We don't have a sense yet of how that's going to play out, but that's something that we need to keep on our radar. Also heard a lot about $1 million therapies, these gene therapies. There's been just continued discussion on the growth of these gene therapies. We're expecting something like 10 to be approved each year by the FDA beginning in 2030. So we've seen the beginning. We haven't seen the end of these multi-million-dollar gene therapies, and that's going to continue to put pressure on plans. We've talked about biosimilars, and I'm excited to hear what the carriers each have to say about their biosimilar strategy. And then cancer, well, we're all continuing to look on diabetes. Obesity is a chronic disease. We also can't keep our eyes off of cancer as a continued area of growth for pharmacy. Let's go to the next slide. I just wanted to talk a little bit about just to level set on when we talk about PBM and pharmacy benefit, what that means. Can we go to the next slide? Thank you. So when we talk about PBM or pharmacy benefit managers, typically what they are is they represent the middleman between pharmacies, drug wholesalers, manufacturers, and employers. What PBMs do, they negotiate drug prices on behalf of the clients, and then they process prescription drug claims. That's at a super high level of what PBMs can do. If we go to the next slide, we have a little more detail of what are typical activities when you hire a pharmacy benefit manager, either through a carrier like you do today, or if you were to hire one directly. Go to the next slide, Maggie. These are the typical services that we would see a PBM perform. So they'll do drug price negotiation. That could be done directly or through like a GPO. They're going to process pharmacy claims using a real-time claims processing. They manage the network, meaning that they contract with individual pharmacies to provide access for members to get their prescription filled. They offer mail order and specialty pharmacy mail services. They perform utilization management, as we talked about in November. That means efforts to make sure that the right member is getting the right drug at the right time. And so making sure, especially high cost drugs or drugs that have potential for side effects, are not being used inappropriately. They also perform formulary management. So when there's multiple drugs available in a class, looking both clinically and cost-wise to determine what is the best agent to be on the formulary to be available for members. And then they do the rebate administration and negotiation. So that's kind of big picture. When you're hiring a pharmacy benefit manager, this is what you're hiring them to do. Let's go to the next slide. And so this is when I talk about disruptors, this is kind of what we're looking at. So when we look at PBMs in the market, there's the big three we'll hear are CVS, Express Scripts, and Optum. And the big three still do control about 80% of the market for pharmacy benefits in this country. However, we're seeing this kind of explosion over the last couple of years of a lot of new niche vendors that are jumping into the space. Overall, we think this is a good thing because more competition always means more opportunity for innovation and hopefully reduced prices for the whole system over time. What we've seen here at Mercer is over the last 15 months, 1 out of every 3 of our RFP projects have included a non-big 3 PBM. So we are starting to get a lot more experience with some of these niche vendors. We're seeing them gain traction in the marketplace. Are they selected 100% of the time? No, they're not. But it is good to see their bids come in and be able to evaluate them alongside the big 3.
So
Go to the yeah, go ahead.
can I just
Mhm.
clarify what this is saying? Are you saying 1 out of 3 successful RFP project decisions has included one of the non big 3 PBMs? Is that what you're saying?
Oh, good clarification. What I'm saying is 1 out of 3 of our RFPs, we've received a bid and we've evaluated a bid from
Oh,
one
okay.
of these entities. So
Okay.
it's an indication that like employers they're interested in looking at these vendors and the vendors are interested in bidding on new
Got
business.
it. Okay, thanks.
Yeah, thanks for clarifying. Okay, so with that, let's move on and talk a little bit about planning for your RFP. And so our ultimate goal, right, for PEB is you have a 3.4% cost target. So what are your opportunities, right, to keep that cost target down to 3.4%? And we saw over the last year over year, you made it. That's great news. How can you continue to have savings at that level and keep trend low? So these are some of the different things you could look at in order to achieve that goal. And we know that PEB is interested in adding additional services, things like GLP-1s, other services for your members. In order to do that, you need to achieve savings and keep that pharmacy benefit trending low. So options you can look at, and we'll look at each of these in a little more detail. You can look at your structure of your options. So right now, as we talked about, you're carved into your medical carrier. You could look at a carve out option. And as you'll see, we would recommend that you look at both carve in and carve out for your RFP to see all of the opportunities available. You can look at your pharmacy network. Right now, you're offering a broad network for members. There might be opportunities for savings with a limited pharmacy network. We'll look at that too. There's pros and cons to doing that. And I really appreciate the comment that came up around pharmacy deserts and thinking about access there. You can think about formulary. And again, this could be done within your existing carriers, but there are all of the vendors offer different formularies. And as part of an RFP process, we can evaluate the formulary that they're offering, both in terms of potential for cost savings and potential for member disruption. You can look at specialty. Right now, you already have exclusive specialty. I'm not sure how much additional opportunity there might be on specialty, but we would want to look at a minimum, the financial terms offered by your bidders. And then financial model. So RFP is really an opportunity to have different vendors bid. And there's really an incentive for them to put forward their best offer so that you can identify the most chance for savings. Yeah, Sean has his hand up.
Yeah, about the mail order dynamic. I'm not sure exactly how the mandatory thing would work, but I'm wondering, have you seen anything in an RFP that would be kind of like a target percent of the members using mail order as kind of like a performance guarantee kind of thing, as opposed to just making like a blanket, like you all have to use mail order the end. Just, where it's more like on the carrier to like the plan to make it convincing. Yeah. You see anything like that?
I haven't, but just because I haven't seen it doesn't mean it's not possible. One of the things to think about is what would what could the carrier do to make it more attractive outside of something like a copay incentive, which is something that the board could establish. But we could add that to our list of questions and ask, what could you do to try to incent more mail order outside of a mandatory requirement or outside of a cost share improvement? That could be a question we could ask as part of the RFP. Okay, let's go to the next slide and we'll talk through each of these in a little more detail. So structural options, carve in versus carve out. So what you can see here on the left, this is a chart that really just shows that what we've seen here at Mercer, this is from our Mercer National Survey of Employers. Once you get over, 5,000 employers, we do see that the majority of employers do carve out rather than carve in. So in that middle bucket, the 5,000 to 10,000, it's over 70% carve out. With the 10,000 or more, it's 66% carve out. There's advantages and disadvantages to both approaches, but we would definitely recommend that as part of your RFP, you solicit both carve in and carve out bids so that you can evaluate both of the options and see if there's any opportunity for savings with carve out. Advantages of carve in is you've got one administrator, right? One contact, one ID card, one point of contact for the members. There's less data transferring that needs to go on, and sometimes that means less fees for data integration. Carve out, you get a vendor that their sole focus is pharmacy. Sometimes we see better financial terms with carve out. It's not 100%, but we do often see better terms with carve out. So that's one of the reasons we think it's worth it for you to take a look there. Sometimes you get more reporting and analytics with the carve out. And then you can sometimes, and this isn't always the case, but sometimes you can get quicker implementation of changes related to pharmacy in a carve out vendor because that's all they do. But I would say that's not 100% of the time, but it's something to consider. Any questions, comments?
Yeah,
go
I
ahead.
just wanted to clarify. So Kaiser doesn't offer the carve out, right? Or do they with some of their folks?
Generally they don't. Generally Kaiser is, if you were to do a carve out, usually membership would stay in Kaiser. However, I think there are some cases like for California Medicaid, for example, where they do carve out of Kaiser. Representative?
I mean, this is an interesting conversation. I think it doesn't work for us to require Kaiser to carve out. That's just not their program or how it works for them. And I just think that's not a thing worth asking.
It is the most common configuration we've seen where there's, even if there's a large employer that carves out pharmacy, if they have a fully insured HMO like Kaiser, the pharmacy stays in the fully insured HMO.
It's part of it's built into the fabric of the way they design their benefit approach.
Yeah, I think that's a reasonable suggestion and we would be aligned on that as well. Any other thoughts on carve in versus carve out? Okay, let's continue. So we think about network options. So this is a continuum and this is similar to a slide that you saw back in November when we talked about pharmacy. So to the left, we've got the least aggressive network options, and that means least member disruption, more pharmacies available, but also the least cost savings generally. To the right, there can be more cost savings and more member disruption. Where you are today, Kaiser current state is all the way over to the right. They're the most aggressive. Moda and Providence are kind of in the middle. with moderately aggressive. So looking at one-time acute prescriptions, so those are like, you'll hear it referred to as retail 30. So a 30-day supply of a one-time prescription. Least aggressive would be there's a national network of pharmacies, including all the major chains. That's what both Moda and Providence have today. The most aggressive would be a narrow network that only includes certain pharmacies. So that's what Kaiser has today. Typically, the amount of savings you can see on a one-time retail 30 network is 0 to 1%. And that's because most prescriptions tend to be maintenance prescriptions. We look at maintenance prescriptions. Least aggressive is there's a national network of retail pharmacies and there's no mail order requirement. In the middle is the member could be provided an incentive to use mail order, and that's what Moda and Providence have today. And then on the far right would be most aggressive, meaning that the member is required to use mail order or a specific pharmacy chain. Savings available through going all the way through the networks to most aggressive tends to be 0 to 3%. On specialty medication, member can use any specialty pharmacy would be the least aggressive. The most aggressive is where all three of your carriers are today, where the member is required to use the PBM's exclusive specialty pharmacy. And that potential total is 0 to 2.5%. And so when we hear employers in California thinking about that bill that might or might not be signed by the governor, there is some concern about most employers like you have adopted exclusive specialty. What happens if they no longer can offer that anymore? Could there be some loss of savings there? Any questions on network before we go on? I think what we wanted to get out of this is to understand where the board sits in terms of network. Do you want to continue to sit in this moderately aggressive where you are today? Or as part of the RFP, would you want to look for more narrow options, especially for maintenance drugs that would be either mail order or a specific pharmacy chain? And again, there's pros and cons to that. You could get some additional cost savings by limiting the pharmacies that members could use, but it also could be disruptive, and there also can be impacts to local pharmacies if they're no longer in the network, given that you're one of the largest, not the largest employer in the state.
So I just wanted to clarify, just because the way the slide's set up, the Moda and Providence current state for the specialty is under most aggressive, just like
That's
the Kaiser
correct.
current state.
Yes.
And then Moda and Providence both sit in moderately aggressive for the one-time acute and the maintenance. Is that right?
For the one-time acute, they're in least aggressive.
Okay.
And for maintenance, they're in moderate. Yes. Yep.
And the most we would save, I mean, I just want to understand the slide is 0 to 1%. If it became more aggressive is what this is saying?
Yeah, so for the one-time acute, so really limiting your retail 30 network, it's usually about 1% is the most you can get out of that. And that's just because they're one-time prescriptions, they're not specialty drugs. Whereas maintenance prescriptions, so those are the medications people take on an ongoing basis. Going to a more aggressive where you're limiting which pharmacies members can use for their ongoing prescriptions, you can get up to 3% savings typically there is what we see in offers.
Okay, thanks. I mean, I guess but if you're asking where we said, I think it would be challenging, particularly with one-time acute medications, to really restrict people where they could get those.
I would agree. And I think the one-time acute prescriptions, there's not that much savings there anyway. I think the question is more, would the board want to look at a more restrictive network for the ongoing maintenance prescriptions if there could be savings associated with it?
And where we would have mail as an option.
Yeah,
Right.
Typically the way it's set up is that they'd be required to either use mail or a limited set of pharmacies.
I mean, I'd be curious, Emily and Greg, what you think about that when we talk about rural areas of the state.
So I don't know if Greg wants to weigh in, but so for moderately aggressive, or can you restate the question?
Well, my understanding is, are we at moderately aggressive right now? That was my understanding. We're at moderately aggressive for the maintenance drugs.
Mhm.
And would we want to make it even more restrictive, to get more savings? And how would that impact our rural areas of the state in particular? Because I'm making the assumption that that's where we have fewer options.
Yeah, and I feel like I've heard a lot of anecdotal stories from our members in rural areas that yeah, they already have less options. So I wouldn't want to go in that direction of limiting um, even more. I don't know if is that what you're asking, Siobhan? And then I don't know if Greg wants to weigh in too.
Well, so a question, I guess a question is, does this take into, and I'm sure it kind of does this take into how many individuals are using the Costco? How many individuals are using 90 days out? How many individuals are using, for these individual drugs that we are selling, or not selling, but that we're getting to drive some more savings? Or is just an overall, or if you understand what I'm asking?
Yeah, I think you're asking, well, so like, for example, you have that Costco 6 for 6 program, or how many members are using that. So what it has to do is usually the PBMs will guarantee a certain network discount rate. And if you agree to a more limited network, they'll give you a more aggressive guarantee on that discount rate. And so by steering more of the utilization to certain pharmacies, they're willing to accept lower reimbursement. So it's kind of a volume, if that makes sense.
Yeah, that helps me in what I was, because I
And
don't know if these rates, take into account if we steer more people towards A or B, then we could move one way or the other because we're saving more by putting more people into those categories. So, but I understand. Thank you.
I do want to bring up, Chandra was kind enough to correct me that the MODA network actually does not include CVS. So CVS is excluded from both the one-time prescriptions and the maintenance prescriptions in the MODA network. So thank you for that clarification.
Okay.
Go ahead, Sean.
Well, it's a good discussion that we're probably not going to settle right now. And I'm not the definitive voice on like rural access. But it occurs to me that there's quite a big of a difference between a one-time acute situation prescription and a maintenance drug. So like if I do not live in a rural area, so I'm just saying, like, I'm imagining living in a rural area, which doesn't go very far, I admit. But I can imagine if I lived in a rural area and my choice is to go to my nearest pharmacy, which might be already like 30, 45 minutes or an hour, maybe, depending on where I am, versus ordering a mail order and have it delivered to me or my local mailbox area, wherever that is, which presumably is closer. If it's a maintenance drug and you kind of know your pattern, there's a benefit of that. You get a 90-day supply or more, which also has, by the way, some emergency preparedness benefit of having that kind of larger prescription for, just like wildfires or whatever it is. Versus I need an antibiotic right now because I have this infection right now, then you don't want to wait on a mail order thing, right? You want to, even if it was overnighted, that's not probably what you want to do, right? So that feels like a different thing. So I'm just throwing that out there for the sake of nuance. That there might be an opportunity to have a more limited mail order system for maintenance kind of stuff. But then you you have a different set of rules for kind of like acute things that you kind of need right away. And it's like, yeah, I'm gonna drive 2 hours to that pharmacy or the nearest pharmacy in order to get that antibiotic right now because, whatever, I have an abscess or whatever it is. So just that's a nuance that for the sake of the RFP, that might be worth discussing later further.
Yeah, Sean, I think that that's a great point, and I'd say that's probably the most common configuration that we see with large employers. That for maintenance drugs, there's a requirement to either do mail order or a limited network of pharmacies, but then acute medications, there's a broader network. That is what we see most commonly, and there tends to be some opportunity for savings through that kind of configuration.
And I was understanding that you're probably a good part of our cost driving situation isn't really with that acute one-time category anyway.
That's
right?
correct. That's
Okay.
correct. Yep.
Yeah.
Marie, did you have a comment?
Well, we can definitely look at some of the data, and we do have to retreat to help flesh out these topics a little bit more. We can look more at the actual pharmacies utilized by the members, at least the ones in-person ones, and compare that and see that like in the rural locations to see like what are the numbers and which pharmacies are currently being used, and potentially maybe even map it up against the zip codes of members to try to see if there's actual lot travel or where there are potentially deserts for pharmacy. So we can take a lot of this back. I think one of the key points we want to do here is really at least get the board members to think about the trade-offs right here, where how much savings do you need, and what are how much member impact are potentially could be out there and might be willing to tolerate in order to be able to meet that 3.4%, because there are definite savings that are out there, but there are restrictions around it. So at least getting that thought and thinking about it over the next couple of months will be very helpful in terms of shaping the RFP. And if you want to shape the RFP even more, you can also help out with, reviewing and drafting. But, it's just, it's really, we want to get you to think about it. And we know we can't get the answer right now, right? I mean, but this is a great discussion. And I don't know, and we can definitely get some mind that you might want to have answered.
Yeah. That was one of the questions I was going to ask towards the end. It would be helpful if you could remind us, because I think we've looked at it before, what our current mail order utilization is by plan. That would be helpful. It would also be helpful, I don't know how to do this, it may be working with SEIU or something, I'm not sure, but it would be helpful to get a little feedback from some of the members who are and aren't using mail order, and just like what goes into their decision about that. Like there might be something we're just not thinking about, like what's the barrier. I don't know, just some qualitative data like that. I don't know what our options are there, but maybe a little panel of folks or something. Or I hate to suggest a survey because people are surveyed out, but it would be nice to have a little member feedback on like people who use it and people who don't. Like is it just like awareness, or is there some kind of barrier to mail order that we're not thinking about? Anyway, just for that later discussion.
Okay, great. Yeah, this was a great discussion. I think it gave us a lot to think about as we get ready for the retreat and getting the RFP together. So let's look at the next thing. We got 3 more, I think, to make it through. So formulary management. So we talked about today, you have the most aggressive formulary that MODA offers. Providence, I think, maybe offers a more aggressive one. They can correct me if they're on. And then Kaiser has their aggressive formulary. What you have today is an exclusionary formulary, meaning not every drug in the universe is covered. And you saw that in the results of that bouncer report, where a lot of those low value products are being excluded, and that's good to see. You have 3 tiers right now. So you're aligned with what we typically see in the market. What we are seeing is development. Some of the PBMs are offering more generic-centric formularies where they're trying to push more of the utilization to established generics rather than newer brand name products. There can be, I've heard an estimate of, up to 3 or 4% savings from going to something like a generic-centric formulary. The downside of that is that then members don't have access to some of the newest versions of medication. So it's really a question on, again, trade-offs. Is a formulary strategy something that you really want to look at as part of your RFP process and ask the bidders to present their most aggressive formulary in their bids in the RFP so that you can see what the potential savings are, recognizing that a more aggressive formulary strategy could lead to more disruption for members. Representative.
I just want to say that I would like to see aggressive, generic-centric proposals suggested, because I think this is one of the ways that we can more easily manage the 3.4%. And then I'm assuming that you can create a formulary that has a process for an exception as needed if something has to be brand.
Yeah, typically that is structured so that there's a formulary exceptions process available for true medical necessity.
I just think this is a place where we can do good work, and I think still offer a superior benefit and maintain the kind of costs that challenge that we're trying to deal with.
So maybe something we think about for the RFP is we could ask the bidders for both their exclusionary, their closed formularies, as well as if they have a generic centric, I've heard it referred to as value formulary. There's different names, but we could ask them to bid maybe their 2 most aggressive formularies so we could see what that would look like. Okay.
Yeah, I
Great
agree.
feedback. Let's go to the next slide. This one is just another discussion. We just went through some of this on formulary, and this is just really showing the balance scale between different approaches on formulary. So I think in the interest of time, let's keep going. On the next slide, let's talk a little bit about biosimilars. So as I mentioned earlier, we asked each of your current carriers to talk about their biosimilar strategies. So you'll hear a little bit more about that later today. But we had something interesting happen in the market in the last year. So Humira has been the #1 selling drug in the US for many years until I think Ozempic took over. And in 2023, multiple biosimilars became available. And what we've seen is 3 different strategies coming from PBMs. And you might hear about some of these from your existing carriers. So some PBMs in the market we've seen are continuing to prefer Humira brand. So the brand name Humira is still available, either exclusively or it's co-preferred with a biosimilar, which means the member has the choice if they want to do the brand or if they want to do the biosimilar. Sometimes there's a difference in copay, but not always. We've also seen some of the major PBMs exclude Humira from the formulary entirely, replace it with the biosimilar, and then work to transition members to the new formulary agent. Third strategy we've seen is where Humira is removed from the formulary, but existing utilizers, so people who have been established on Humira, are allowed to continue using Humira, while any new starts are required to use the biosimilar. So when you look at formulary strategies, both through the RFPs and then also while you're talking to your current carriers, things to think about is request net price information if that's available. So it's always good to understand why decisions are made and what is the net price for the brand and biosimilar. We talk a lot about transparency in pharmacy, but it's really difficult to determine what a net price of the drug is, especially if you're getting rebate data in aggregate, not at an individual drug level. Definitely want to talk with your carriers, understand what are they doing to limit transition to newer and costlier drugs that are in the same family as Humira. So for example, Skyrizi is used for many of the same conditions as Humira. It's actually made by the same manufacturer as Humira, but it's newer, doesn't have a biosimilar, and it costs more. So what are your carriers doing to prevent that? And then also think about, is there an education campaign that either you could do or your carriers could do to provide education on biosimilars? And we've got Humira now. Stelara, we're expecting in the next year, is going to be the next biosimilar, and then there's going to be more coming. So it is really important to think about what a biosimilar strategy looks like. And that's something that you might want to include in your RFP, asking any of the bidders, what is their strategy? Sean, I saw you had your hand up and then you took it down.
Yeah, I don't know what the right time is for this, or which slide, so I'll just throw it out. For our future discussion or retreat, I seem to recall at one point when we were talking about pharmacy, we had some kind of discussion about sometimes plans have rules about direct advertising, this sort of thing, to physicians, their own network. So anyway, I don't know what that looks like, but it's like sometimes there's expectations on physicians about like the amount of pharmaceutical direct sales they get, where they start privileging certain drugs because they've been influenced. And so that's just all kind of related around the communication around biosimilars, for example, like it has to be this brand instead of generics, that sort of thing. So that would be interesting to talk about if that's ever been written into any kind of RFP or an expectation of plans. Like, do you have policies as a plan related to that, and so on? So that's one topic we can talk about later. The other thing is that I don't want to lose track of is at one point we had quite a discussion, as I recall, around opioids. And there's sort of two things about that. Well, there's a lot of things about that, but sort of two things about it is, one, there's a safety issue, and two, there's a cost issue. And it's like, what expectations do we have? Most plans have some kind of policy related to opioid, prescription control, the number of prescriptions you can give. They have a monitoring program of their physicians, that sort of thing. And do we want to have some explicit questions, expectations, or whatever in the RFP about that? Because it's both a safety and a cost thing. So just putting that out there for our more detailed discussion later.
Yeah, great call outs. I know our standard RFP questionnaire does ask about opioid programs. So the bidders would have to describe their opioid programs. And we can work with you to make sure that the question captures what you're looking for. But yeah, we are looking to understand, do they have a limit on morphine equivalents per day? Are they doing utilization review coming from the doctors? So yeah, absolutely, we want to look at that. And as to your other question, yeah, let's take that back and think about what would that look like? And what's a reasonable expectation for the bidders in terms of, some of this advertising marketing piece. Okay, let's keep going. Specialty drugs. So we've talked a lot about specialty drugs. You saw that some of those top drivers are specialty drugs. Something to be aware of is we often, when we talk about PBMs and PBM revenue, specialty drugs are a growing component of that. So, as you know, exclusive specialty pharmacy is the norm. All three of your carriers currently limit specialty drugs have to be dispensed by one selected specialty pharmacy. What we've seen is in 2015, 17% of PBM gross profit was coming from specialty dispensing. That's up to 33% now. And some of that has happened as there's been more squeezing on other sources of revenue for PBMs. But at the same time, we've just seen this explosion of specialty drugs. And so one of the things we'll want to understand in the RFP is, how are you getting savings from an exclusive specialty arrangement, and make sure that the financial terms that you're being offered for specialty drugs are as competitive as we can get in the market. We have seen some clients look at specialty carve out where they'll essentially do a separate RFP just for specialty drugs and hire one vendor to just manage and dispense specialty rather than including that in the larger carrier or PBM contract. While we've seen a lot of interest in that, I'll tell you, I don't think the savings has been borne out yet. It's something that we're continuing to monitor, and if we're seeing savings there, it would be worth exploring. But it's really new, and as of today, I can't say that would be a good source of savings. Our proposal at this time would be for the RFP to keep specialty drugs within within a PBM or carrier contract, either carve in or carve out, and that we negotiate to make sure that you're getting the most favorable specialty terms. Any comments on that? Okay, let's keep going. Transparency. So we've heard a lot about transparency in pharmacy, and we've had a lot of discussions both internally. I think we've had discussions at this board about, what does transparency mean for PBM? It's the buzzword, but there's not a consistent definition. We hear transparency a lot in the context of PBM spread. And certainly your contracts today are pass-through contracts, meaning there's not spread. So spread, for those of you who aren't familiar, means it's a PBM contract in which the amount a PBM pays a pharmacy for the prescription is lower than the amount that the PBM charges to the plan for that same prescription. And that difference, the PBM retains as revenue to fund their operations. So your current contracts do not include spread, or at least not direct spread. But the PBM spread has gotten a lot of news as of late. And so one thing you want to think about with your RFP is, do you want to allow bidders to bid with contracts that would allow spread, or do you want to ensure that you're continuing to get pass-through contracts? In a truly transparent contract, the PBM's only source of revenue would be an administrative fee. And we are starting to see, when we remember that pie slide with the 3 big carriers and then all of the other niche PBMs, we're seeing a lot of those new niche PBMs come out as transparent to differentiate themselves against the big 3. Why are we seeing the growth there? Again, spread has gotten a lot of bad press lately, and in many cases for good reason. There's a perception that transparency will lead to lower cost. Sometimes, but not always. We have seen cases where we'll do an RFP and we'll receive both transparent and traditional offers, and the transparent offer isn't always the most advantageous cost-wise. Sometimes there's a price to be paid for transparency, but for some plans, it's worth it to better understand where their money is going. So yeah, go ahead.
Yeah, I just had a question because, the slides show how much, costs have increased in certain areas. Do we get overall profit margins for these PBMs? Like, which ones are doing really well, therefore, like, getting a lot more out of the spread or whatever? Maybe it would be helpful to see something like that, because if a PBM is just charging an administrative fee, you said they just make that administrative fee. So did folks do those comparisons to see who's making the most money and therefore not giving better prices?
So we're starting to see movement in that direction. So there was some federal requirements called RxDC reporting that was required a couple of years ago, and some of that reporting is including spread. So we're starting to finally see a better idea of how much different PBMs are collecting on spread on different clients. But that's something that I want you to consider. In the RFP, you can define what you're expecting in terms of transparency. So it's really an opportunity for you to establish the parameters on how much transparency you're looking for. But as far as aggregate, do we have an aggregate of how much PBM spread is CVS Caremark getting compared to Optum? We don't have that today. That's not reported publicly.
I shouldn't be surprised. Looks like we have Sean and then representatives.
So yeah, so two things. First, I don't mean to put this in position as if they're an opposite, but they might be dynamics that are negotiated around. I'm curious, if not today, maybe at our retreat, if you're aware of any performance guarantees that come along with some of these PBMs and even related to their spread or whatever. It's like, well, if we're going to allow you to do spread, then we want a guarantee that, prices are not going to increase this and this amount over 3 years or something. So I'm just throwing that out there. Or if the market has experimented with that, or if you're aware of that at some point, that could be a future discussion some other times. Just throwing that out there. And the other thing I was curious about when we were talking about specialty drugs, and I think I asked this every time we're talking about pharmacy, and everyone corrects me every time, so I appreciate the patience. We're not talking about drugs that are administered in a clinical setting, right? We're only right. That's separate, right? That's in
For this
that's in
discussion,
medical.
that's on the medical. That's right.
Okay.
Yep, but that is a growing component of pharmacy.
Right.
We can't ignore it, so that the medical RFP is going to need to contain some provisions around those
Okay.
medically administered drugs. Yes.
So around that, whenever the right time is to talk about that, I would like to talk about site of care language in the RFP. So I just want to put that out there. Okay, I'm done.
Great suggestion. Thanks.
Were you planning to chime in, Representative Ness, or no?
I changed my mind.
Okay, so let's go to the next slide. And this is just where I think we want to think about as we move to the RFP, are there opportunities for you to ensure that you get transparency, the transparency that is most useful? And so when we think about what does meaningful transparency look like, the box on the left are components. In Mercer's opinion, we think they should either be reported or passed through to the plan sponsor. So if they're passed through, great. If they're not passed through, then they're reported, and then you're understanding how much of the PBM's revenue is coming through these sources. So that includes things like a spread between a pharmacy and the plan. Any pharmacy payments to the PBM. So sometimes you'll hear that referred to as DIR fees that the independent pharmacies or the other pharmacies have to pay into the PBMs. You want to understand that. Any off invoice discount incentives, so other incentives from the manufacturers. 340B, discounted drug prices. In a perfect world, you would understand what's out there for 340B. That's a discount drug program that's available to safety net providers. In terms of rebates, definitely want transparency into 100% of any of the manufacturer rebates received. And today you do get 100% pass through on those rebates. So that's great. You would want that to continue. And then also you would want some transparency into the GPO revenue. So these GPOs are negotiating the rebates on behalf of your carriers today. And there's really not a lot of transparency into the revenue that's coming into the GPO. So that's something you could use your RFP as an opportunity to try to press on. In an ideal world, we'd like to see rebate reports at an NDC 11 level or at a drug level. What I mean by that is rather than just seeing that you received, I'm making up numbers, $5 million in rebates this quarter, wouldn't you like to see how much of the rebate is coming related to Ozempic, or how much rebate did you receive on Humira, or at a minimum, just at a therapeutic category where that rebate is coming? So you could think about for your RFP, what do you want to ask for in terms of rebate reporting? You also want reconciliations. You get these different guarantees. Sean, you were talking about guarantees. We do usually see discount guarantees or rebate guarantees. We'd want to make sure that the contract doesn't allow those guarantees to cross-subsidize each other. You don't want it set up where your PBM or carrier can overperform on one guarantee and then allow that to cross-subsidize underperformance on another guarantee. You want to make sure they're meeting each of those guarantees individually. We would recommend that you want audit rights for 100% of the claims, all the way back to the pharmacy acquisition costs and all the way back to the manufacturers for rebates. And again, it's this transparency that you have access to the information, not necessarily that it's happening at the time the prescription is filled at the point of sale claim, but that after the fact, you can understand where all the flow of the money is. And then also we want to move towards what we're calling total revenue disclosure. So the total PBM and the GPO revenue source reports that are unique to you. And so if for example, you hire a PBM, you don't want a revenue disclosure statement that's just for their entire book of business. You want to understand what their revenue is for PEBB. And so those are the kind of things we can ask for as part of the RFP process and evaluate each of the bidders or the carriers in terms of what they're willing to offer for transparency. Kimberly, you have your hand up.
Hi, I just want to ask, is this something, this isn't unusual? This is something that carriers are doing for other books of business, and so this would just be something that we would be adding to what PEBB expects from our carriers?
So most of this we have seen for some clients, it's not universal. PEBB is larger. We think you can push the envelope, especially around the rebates at the drug specific level. I do have a couple clients that get that. The smaller clients usually don't. Audit rights, I think that's table stakes. You should ask for that. The guarantee reconciliation, same thing. But we are really pushing for the total revenue disclosure. And I'll be honest, some carriers and PBMs have been better than others in wanting to participate in that effort. So I think we want to push for it. That is the end of my formal presentation on RFP planning and pharmacy. We have a couple minutes if there's other questions, other comments, other things that the board really wants us to think through as we move towards RFP. We can go to the last slide. So these are all of the different aspects we talked about today. I think what I heard is, or we see the stars there, we want to think about the structural options, look for both the carve-in and the carve-out bids. As far as network, we heard that we're interested in getting bids on a more limited network for the maintenance drugs to identify what the savings opportunities might be. Also heard on the formularies, we're interested in getting bids on more aggressive generic focused formularies where they're available. And then on the financial model, I think I heard mostly agreement, or at least not disagreement, that we want to go for not only improved financial terms, but also ask for some improved transparency around pharmacy.
I really appreciate the last slide. I mean, the one that preceded this one that kind of lays out some of the ways we can get at that improved transparency as well around the auditing. So I really want to appreciate all of the information that you gave to us to think about, super thoughtful. And, I imagine some of this will come up in our retreat discussion as well. We certainly did keep to time. That is impressive. Though I know you offered if anyone has any last questions before we take a break. Go ahead, Emily.
Yeah, I echo what Siobhan said. This was super helpful, very impressive, how much information you got in there. And then I'm not sure how to articulate this question. I've brought it up in the past. It's not directly specific to pharmacy, but I'm thinking of alternative health and healing practices. And then just like, I think I'm having to understand more from an equity perspective. I know like tribal and communities of color and immigrant communities often tend to lean towards more natural health and healing kinds of interventions or just therapies or treatments. So even like, my mother who had a stroke last year, like acupuncture and massage therapy, like right away after the stroke, regular treatments really helped her heal fast. And just, at first she lost like the feeling on that left side of the body and wasn't able to walk. But then after the acupuncture and massage therapy, she's able to walk again and do everything. And so um, this may not be the place for this, but I'm just, curious as to like for the RFP, is there an opportunity to kind of strengthen um, those types of alternative health and healing approaches?
Yeah, so those, they're on our radar, and the Health Equity Committee is working on ideas for how they could be tied to or incorporated into the RFP. I saw Emery come on. I didn't know if there's anything else to add there.
Not really, no. I mean, it is, some of those items are on our, our list of items to look at and address. And yeah, we'll take it away, and we can have more discussions, maybe potentially at the retreat, and write some questions around it. But definitely noted, and
Okay.
we'll keep it on our our list of items.
Great. I feel like that's a strength in the Pacific Northwest, especially in Oregon and Washington. Yeah, sort of so many naturopaths here and Chinese medicine doctors that aren't always present in other states in the country. So just trying to integrate some of that health and healing also. Thanks.
Yep, I mean, yeah, naturopaths and acupuncture and all those other, they are definitely been topics that have been coming up. So we know it's of great interest for PEB members. Sean, do you have the question?
Well, I was just gonna add on. I really appreciate Emily's point there. And it sort of brings up this meta topic that I don't want to lose track of when we're talking about pharmacy benefit management of just the whole point of coordinated care. So if we're having an external the carve out rather than the carve in, something to keep our eye on. Well, even if we're doing the carve in, just that there's a deliberate, thoughtful system that we're trying to articulate in the RFP, that there's an expectation that there's some sort of coordinated approach, a patient-centered approach, where someone gets diagnosed with whatever, that it's not, they go here for the drugs and they go here for the diagnosis, whatever, and they don't really, there's no connection about like, is that the best approach, which it would be in some cases, but coordinated with health coach or food nutrition or lifestyle management, while you're also going through the pharmacy system, and it's just like, just don't want to lose track of that coordination piece. And a lot, if you have one vendor for this and one vendor for that and one vendor for this, there's a very difficult element of like who threads it together. So just putting that out there.
I think this is the key important issue, actually, what you're raising, which is that PEB is putting together an ecosystem of programs and benefits for the purpose of maintaining and enhancing the health of your people, right? So any piece of that puzzle needs to be done on an integrated basis. And, that we do see divisions even within a carrier in their pharmacy as compared to their clinical management group. And so I think that specifying that interaction and connectivity is a key part going forward of any kind of contracting and evaluation that we're doing, in the service of how effective are you in enhancing the well-being of the people you're serving, which has to be on an integrated basis. It can't be just isolated pieces of the puzzle exactly. So I think that's the most important thing we can do here going forward. That's me, the clinician.
Yeah,
All
and
right.
we actually, sorry, we do have MKO on Mary Kay on tap to kind of discuss that at the retreat. It's a big part of it, especially like the data integration, navigation, and stuff like that. And I know, I think we,
Avery,
You're unmuted.
Emery, you just went
Yeah.
on mute.
yeah, I know, I'm sorry, my cat just jumped across my laptop. So yeah, so I know I think we're running up on time, so we'll turn it back to you, acting chair, I guess.
Yes, we're going to take a 10-minute break. Everyone should be back at 11:25. Thanks, everyone. Hello, everyone. Welcome back from break. I want to make sure we have our Kaiser presenters with us. I've got 3 folks, Dr. Eric Albright, Sunshine Summers, Marty, not sure how you say your last name, Marty, so you can share it with us. Are you all 3 here?
Yes, we are.
Great. So I do want to hand it over to the 3 of you if you're ready to present.
Great, thank you. Yes, so thanks for having us today. My name is Sunshine Summers. I think I've met many of you on in previous meetings, but I'm the Director of Clinical Pharmacy Services here in the Northwest at Kaiser. I also have with me a colleague, Marty Greneweg, who is a manager in clinical pharmacy, and also my colleague, Dr. Eric Albright, is with us, and he's the Director of Drug Utilization Safety, and also is a member of the Endocrinology Specialty Department. Next slide, please. So I'd like to start off with, kind of our differentiator is our integration, and we kind of heard some of that in our previous conversation with Mercer, but basically we are integrated throughout. The pharmacy is part of the whole healthcare team. We have an electronic health record that automatically monitors and alerts pharmacy and providers to any issues with doses, polypharmacy, adherence, interactions, potential abuse, and other possible issues. We are fully integrated, our pharmacy services, and we use information captured in our Health Connect, which is our Epic version, and also in our pharmacy system. They talk to each other. And that helps us with our drug utilization review. These systems contain flags that indicate over or underutilization, and our pharmacists and physicians constantly confer with one another and take necessary action to provide quality pharmaceutical care for the member. So you can see there's other pieces to this puzzle. We are internally purchasing products. We don't rely on a PBM to do our purchasing or contracting. We bake in our evidence-based protocols into our EHR, and then that allows our physicians to really do both cost-effective and high-quality care for our members. And I'd like to go on to the next slide, please. Thank you. So this slide just kind of highlights a few things around our integration more fully. One is our generic drug utilization. So overall, our mix of generics and brand is 94% is generic. So that's including all brands and generics together. And that's higher than the industry standard or US average of around 90%. We also do strategic purchasing. So we directly work with the manufacturers of pharmaceutical products, and we make sure that we have a steady supply of the drugs for a consistent price. We also purchase and warehouse some drugs that may have supply issues to protect those prices, and also make sure that we can keep that. If we know that a price is rising, we can pre-purchase those and warehouse those so that we can enjoy that lower price. We also really prioritize long-term contracts. So those help maintain the supply. And, supply disruptions are a major issue in the pharmacy world, as you may have heard. But these long-term contracts really help us kind of shield ourselves from those. And then rebate-free purchasing, this is key. And you've seen this in the Mercer presentation that that's not our strategy. We directly contract with the manufacturers and get pricing based on our volume. Next slide, please. So this is just a few things that I wanted to iterate or to emphasize, I should say. One thing is that we have a regional drug utilization action team, and this is focused on not just drug cost savings although we do save an average of $20 million per year. It also is focused on quality. So the Medicare quality, adherence, we do a lot of polypharmacy work, and you'll hear about that later on in the presentation. But that is a key strategy for us, and Dr. Albright is actually the co-chair of that committee, and I'll let him speak to that at the end here. Our generic substitution rate, so this is not just not brands and generics holistically, but talking about when there is a generic available, we use the generic 99% of the time. So we do have patients who, get exceptions and do need the brand, but that's a very small minority. Our approach to the medications we provide, we do substantial evaluation of the clinical efficacy, as well as the cost and the safety, and that's done through our P&T committee. And then we, once we have kind of what we think we need, we take it to the manufacturers to secure a long-term contract on those high-quality products. We are also, as I mentioned before, fully integrated with an EMR, and it has decision support baked in so that it makes sure to kind of make the right thing to do, the easy thing to do for those clinicians. And I'll let Dr. Albright share his perspective here.
Thank you, Sunshine, and thank you for allowing us to present our pharmacy structure and taking time to listen. So this effective and cost clinical management slide really emphasizes a strong partnership that we have between our provider physicians and our pharmacists. And that structure is seen at the regional level with our drug utilization action team, where the co-lead is shared between Sunshine and myself. And we also have service areas where a pharmacist and a physician co-partner in our local service areas. And so we have real-time self-set metrics that we're following. And we're following local trends so we can identify, investigate, and improve members' health by providing safe, effective, and cost-efficient medications and medication options. And that is an incredible resource for us. We share what we see not only in our service areas at our regional meetings, but we also have national meetings. So we have a large conduit of thoughts and expertise that we can pass along to our members. Another comment I want to dive into a little bit more that Sunshine brought up is what I call our trial to treatment. So because of our partnership and our ability of a self-contained network, when a medication is newly approved or a new indication is approved, the speed to which we can have the physicians who prescribe this medication, the pharmacists who support us and help us with our formulary decisions, we can very quickly move to have a set and supported structure where these medications are given to the right members at the right dose with appropriate surveillance ongoing so that we get the outcome for which these medications were either recently approved or released to market. So I just think that dynamic, not only speed, but also the continuity and the follow-up helps significantly in our efforts to take care of the member. I'll turn it back over.
Great, thanks. Next slide, please. All right, and this is just an illustration of our national, as Dr. Albright kind of referred to, we have a national model, and then we are part of that locally here in the Northwest. And so you can see nationally, we are 12.7 million members strong. We have over 550 pharmacy locations, and we have interactions with patients very often, 180,000 times per day on the national level. And then you can see it broken down for the Northwest specifically there as well. And now I will pass it off to my colleague, Marty.
All right, thanks. Can everybody hear me okay? Okay. So if you go to the next slide, I'll start really responding to some of the questions that were posed to us and providing you a little bit more detail on those high priority areas. So the first one being looking at our approaches to intervening on gaps in medication therapy for chronic conditions. And I've really honed in on 3 approaches we have to that. The first one I'll touch on in the middle there is care gaps. So we have the ability to screen through our electronic medical record, our claims data, a real wealth of information in order to identify patients who may have gaps in medication therapy. Perhaps it's a patient with a history of heart attack and we don't have them on a statin medication, which we know reduces the risk of recurrence. So we have an ability to really precisely identify these patients. And then we make it easy for our healthcare teams to know who those patients are and have conversations with them wherever they might be in their healthcare journey. So it could be a provider's office visit. It could be picking up another medication at the pharmacy. We're really looking at any touch as an opportunity to close these care gaps. And then once we have them closed, we're going to take care of the member and make sure they're reaching their healthcare goals. So our pharmacy teams do have a number of programs where we operate under collaborative practice agreements, where our physicians give us the authority to really take on the medication therapy management, particularly for diabetes and blood pressure, and work with those patients until they've achieved their targets. And even then, when we may not be interacting with them as frequently, we do have tools in place to make sure that they are continuing to take the medication as prescribed and being what we call adherent to their medication. We have tools like refill reminders by text and keepy.org message, which is kind of like an email. And we also have tools that patients can set up to set their own daily reminders for when it's time to take medications. And if you'll go to the next slide, want to show you some PEBB-specific information related to this. I mentioned some KP.org tools that we have in place, and you'll see on the bottom half of the screen there, PEBB members in particular are really engaged with these tools. We're showing Q2 volumes where PEBB members are filling just shy of 250,000 prescriptions, and over half of those are being initiated, the fill or the refill, through our online digital tools. And this engagement is showing good adherence rates. On the top half of the screen there are the PEBB specific adherence rates, which are pretty robust. You see blood pressure control and cholesterol adherence rates in the mid-80s, which is great. And to the next slide.
Marty, let's take a minute and just, there's a question in the chat, Sunshine, about how many of the 26 Northwest Pharmacy sites are in Oregon.
Yeah, so we have 4 Washington locations. So the balance, the 22 locations are in Oregon, and we can likely get a map. I don't have it at my fingertips, but we could certainly provide that.
And I just wanted to go back a couple slides to slide 6 and just echo Marty's discussion as far as targeted outreach. I just wanted to share some of my experiences as far as how nimble that outreach can be. And instead of targeted outreach to patients, it's just targeted outreach to make sure that medications are being provided safely and effectively and timely. And to that end, we have a medicine that might be administered infrequently, maybe every 6 months. And there's potential harm if the medicine is not given within a certain time period. With the quick communication with the supporting pharmacist for your program, say endocrinology, you can have pharmacy-supported outreach. We can leverage our access to the medical record and dispensing and ensure that if that patient isn't dispensed that medicine within the time period that day that it is due, an alert goes to that provider so that they can take action, which is amazing. The other piece is in the care gaps is adherence. And through the pharmacy support, we have, as providers, direct line of sight to adherence data based on prescription refills with a quick hover during our chart interaction with the patient. So I can see how many times or the percent refill, so I can address that in real time with the patient and ensure that the medications are not only being taken, but taken at the right dose and prescribed. So we also not only affect adherence, but we also provide medication reevaluation and reconciliation of the list so that we are not having medicines that are no longer being taken continued. And the last piece is the collaborative chronic disease. I can't overemphasize how helpful it is to have that extension of a specialty pharmacy team that can help you in management of these chronic diseases. You have another touch point of someone who is highly skilled, it's personal, it's expert supported, and we have internal review looking at the impact of this supported team. And just with 6-week interventions, say in diabetes, we see preserved and continued improvement in A1Cs 9 and 12 months past the original 6-week intervention. So it's a very effective and sustainable process. So sorry to jump in. I just wanted to share that.
No, really appreciate it. It's a good segue into our slide around polypharmacy and deprescribing. You mentioned trying to make sure our med lists are clean and patients aren't taking medications that aren't indicated. And this really is a focus, particularly in the realm of polypharmacy. And here we put considerable attention towards the combinations of medications that pose safety concerns. So we spend time looking at drug interactions, medications that have abuse potential, times where patients might be on multiple medications that increase the risk of fall or cognitive decline. And we're really focused on this for our particularly vulnerable patients, so patients who may be frail or have multiple comorbidities. And our approach here is not just focused on deprescribing. We do have good data to identify those patients and make recommendations and help them taper off medication, but we also put substantial effort into preventing patients from getting to the point where they're on multiple medications. And again, I feel like our structure at Kaiser, we have a saying that we are physician-led and pharmacy-supported, and we have a lot of structures in place to support that with polypharmacy. Sunshine mentioned our regional drug utilization action team. That's a committee of key stakeholders who have both representation and influence on our performance in these areas. We leverage tools within our electronic medical record to guide decision making and make sure providers and prescribers have all the information they need to make the right decision and make it easy. And then we also engage our patients and providers and make sure we're giving lots of education. And aside and all of that combined, we do also offer high touch pharmacist interventions for the higher risk patients. So tapering off opioids is a good example where we've been quite successful. Anything you would add here?
Yeah, I'll just jump in for a minute. I think it's the amount of support is just unbelievable, and the collegiality we have with our pharmacy teams. The thing that impresses me is when you have immediate line of sight into patients' prescriptions, because it's all internally dispensed, controlled. So even if I'm not the prescriber, I will have visibility of what the patient is actually filling and possibly taking, right? So that allows me a better decision-making at time of prescribing. And when we enter a prescription into our EMR, we have worked very hard to build and revise alerts that help us identify combinations where other considerations may be beneficial. And within that alert, you've got other options as far as additional learning, additional treatment options. Sometimes in certain medications that might have multiple uses, but there might be a better use for the diagnosis. It might trigger you to find a smart list, which has disease-based treatments rather than just a drug list of similar drugs. So it helps guide us into making more informed and possibly better decisions by just having all that information readily available at the time of prescribing. which I think is an incredible advantage. The other advantage is we constantly review and revise so that there's optimal improvement in prescribing and decrease in the amount of interruption of a clinic visit with all of these support tools that are available. Thanks, Marty.
Yeah, sure thing. So with the next slide, we're going to shift a little bit and talk about how we can access members who maybe are not close to our brick and mortar pharmacies or need to access our pharmacies at odd hours of the day. And I really appreciated some of the robust discussion around this topic earlier. So at Kaiser, a backbone of our strategy here really is our mail order pharmacy program. And we have, over the years, really reduced the barriers for patients to use this program. We are now able to deliver medication to 41 states. So even if members happen to be outside of Oregon, we can still engage with them. We do not charge a fee or a shipping cost. We are transparent, providing delivery status updates by text or email, whatever the member's preference is. Members are able to initiate the fill or refill request 24 hours a day, 7 days a week through our digital tools. We use first-class tamper-resistant packaging. And a real benefit to our program is the coordination with prescribers. We're able to really quickly get authorizations for new prescriptions if a patient is out of refills, which means that from the time they request the medication to when it's delivered is faster. And on average, our delivery times are 2.2 days, so quite fast. And we're able to really optimize the medications we're able to offer through our mail order pharmacy. There are limited distribution drugs, but 95% of the drugs on our formulary we can deliver by mail. And because we've been able to really optimize this program, we do see for 62% of our prescriptions, they're going through our mail order pharmacy. So those maintenance medications really are being run through mail order pharmacy. And for PEBB members in particular, there's incentive to use mail order because they can get 3 months worth of medication supply for the cost of just 1 month of medication supply. So while that's our key strategy, we do recognize the need to access, pharmacies, not just deliveries, but pharmacies for acute medication needs. And in those instances, we do have an expanded network of pharmacies. And we do have 24-hour community pharmacies and take-home packs available for patients discharging from our hospitals at odd hours. All right, if you could go to the next slide, please. So now I want to talk about how we really protect our pharmacists' time so that they are able to engage and educate and counsel our members on the medication therapy they're taking, whether it be new medication or questions they might have about a medication they've been taking for a long time. So first, I want to point out that we really protect the time of our pharmacists in our owned and operated pharmacies. We try to make sure that they are focused on serving the member at the counter and in the waiting room. And one of our key strategies here is to have most of the calls that might typically go to a pharmacy serviced by our call center. And because our call center can answer those questions, it really allows the pharmacist to focus on that member that they have at the counter. And we do try to make sure that when they're interacting with patients, they're able to do so in a way that's meaningful to that member. We offer our prescription labels in 14 different languages, as well as accessible formats like large fonts. And we have immediate access to interpreters so that the message that the pharmacist is trying to relay is being delivered in a patient's preferred language, so they're more likely to hear and understand and have their questions addressed. On top of kind of protecting that time at the pharmacy, we also have identified areas where we know pharmacists add value. And in those areas, we've developed pretty robust pharmacist-run programs to provide additional support. And I won't go through every bullet on this slide, but using the top one as an example, we do have pharmacists that help patients who are new to Kaiser, and the pharmacists help them kind of transition to using our formulary products and making sure that they're set up to have the medications they need to treat their disease states, and are selecting the ones that are going to be cost efficient for them. So if we go to the next slide, I'll talk about the topic of the year, which is coverage for weight loss medications, and in particular, GLP-1s. And Sunshine touched on a key strength of ours, which is our scale. We do have large contracting and purchasing power, being a national program. And once we have those competitive prices negotiated, we have the supports in place to really drive utilization to those products that we know are going to be clinically high value and affordable costs. And we do this in a number of ways. I would again say it's collaborative, so developing guidelines for how we're going to use expensive therapies and practice resources. It's all done with our physicians, so we have good buy-in and good support. And then we are supporting prescribers and pharmacists at the time of prescribing and dispensing to make the best product selection. I'll also kind of point out that weight loss is not only managed by medication therapy, so we do lean heavily and coordinate with our colleagues who can provide behavioral health support, social, nutritional, physical support before, having to turn to maybe a more a higher cost option. And the last point I'll make before passing it back to Sunshine is, we do have internal research we do to make sure we're on track and doing well in how we manage disease states. And for weight loss, we do have internal research that supports at Kaiser, we can utilize less expensive generic medications to be clinically effective and help patients meet their health goals in a cost-effective way. So I'll pass it back over to Sunshine to talk through the rest of the questions.
And I know we're running short on time. I'll try to be quick here. Next slide, please. So one of the things you were interested in is our diabetes spend and outcomes. And so here's a depiction of where we have come from and where we were so far this year. We've increased our PMPM cost from 420 to 444. GLP-1 utilization is interesting. We have also increased quite substantially, and you can see since 2021, it's quite a big leap. And actually, if you look at the difference in the numbers, you can see that our GLP-1 utilization is higher than what our PMPM total diabetes spend is, which means that we've offset some of that with other diabetes savings in other areas. So we are using GLP-1s more now. Our restrictions have been loosened based on more recent evidence suggesting their place in diabetes therapy. So I wanted to call that out. And then also just overall, the table below shows that the PEBB members have improved on every HEDIS metric from 2021 to 2023, and are actually outperforming or, doing better than our overall KP region as a whole. Next slide, please. I know I'm out of time, but I want to just briefly touch on our biosimilar approach. And Amjevita, the biosimilar of Humira, came out in March of 2023. And within 3 days, we had converted over 95% of our patients to that product. And that shows the power of our integration and our ability to contract with a product, all get on board and move our members to that equally effective, much less expensive product. And we will plan to do that again. That's our strategy for our upcoming Stelara biosimilar. I know that was a question you had as well. And then I think I'm out of time. I think we have one more slide, but I can go ahead and pass it off if we're out. And I thank you for your time.
Go ahead and, I mean, if you want to say anything on your last slide, go ahead.
Okay, just briefly, specialty drugs, hot topic. We have specialists, specialist pharmacists who are embedded in specialty care departments, and they help us optimize the anti-inflammatories, the biologic therapies that were discussed by Mercer earlier. And in 2023, we were able to save $500,000 by closely managing patients and optimizing the dosing and the frequency in those conditions. And we also have an owned and operated specialty pharmacy that is helping us with cost savings and also just safety and quality and making sure we're abiding by the regulations that we need to for these limited access products. And we're just happy to be here, and thank you for letting us share our story with you. And I'll hand it off to
All
you.
right. Well, thank you to the three of you. If PEB board members have questions, in the interest of time, if you can put them in the chat for our Kaiser folks. Also appreciate the HEDIS metrics to see how well our PEB members are doing, improving their health. And our next presentation, Katie Sheeler will be leading that, and that is with MODA. So I'm going to hand it over to you.
Thank you. And I just want to confirm the time. Shall I go?
You have 20 minutes.
The 30?
Oh, yes. Go ahead.
Okay. Thank you so much. Hi, everyone. My name is Katie Sheeler. It's so good to see you all today. As you recall, I'm a pharmacist by training. My role at MODA is a senior clinical program manager. And as you know, MODA is the administrator of ArrayRx. Mercer touched on so many important things at the beginning of the meeting, and I wanted to just restate the relationship MODA has with ArrayRx and refresh that the board that PEB programs are part of ArrayRx in general, and that they're benefiting from the state of Oregon's commitment to leveraging state purchasing volume and the commitment to improve affordability of prescription medications. So as Kaiser had talked about, having the ability to combine all of their lives and have the scalability to negotiate purchasing power, MODA does the same with ArrayRx when we are having conversations with programs and rebates, and that'll be a running theme you see throughout the slides. Throughout the deck, we'll touch on multiple things that was asked about with Mercer, but we're going to start here on this first slide. Just to recall a few statistics that were shared by Mercer at the July PEB board meeting, specific to the MODA performance, just to set the stage. So we heard in July that the prescription drug costs as a percentage of the total costs have been held stable over the past 3 years for MODA, around 16% up to 16.5%. And this stability in the context of drug costs really is not something you hear in headlines today. We know drug costs are increasing, specialty costs are increasing, and I just thought this was something really to highlight because stability, again, in this market isn't the headlines that we hear. When we look at our risk from the MODA perspective, it was highlighted by Mercer that we were able to achieve the stability of the drug costs despite having the riskiest population behind the statewide plan. MODA had the lowest risk-adjusted costs, as shown by the graph that I snipped from Mercer's slide deck. So thanks for letting me borrow that. So I just really wanted to illustrate how MODA really strives to provide the high quality care to PEB members at a reduced cost, no matter how risky the population is. On the next slide, I wanted to depict what we see from the MODA 2023 Pharmacy Cost and Utilization Report for PEB members. We had an increase in the non-drug spend due to this category is comprised of the continuous glucose monitoring products, and we had a channel management strategy the year before that allows the CGMs to be filled under the pharmacy benefit. And this increase was on purpose because prior to that, we allowed CGMs to be filled under the medical benefit and the pharmacy benefit. That was done. We weren't able to ascertain reliable claim data. And so when we carved out the CGMs and had all of the prescriptions go through the pharmacy benefit, it not only improved access to members so they could easily get them under the pharmacy benefit, but it also increased the savings to PEB because we were able to better ascertain claim data and submit those for reimbursement on the rebate side, which 100% is passed through to PEB. So when I reflect and see the cost and utilization from 2023 and I see shifts and increases in costs, it's always good to remember sometimes it's strategy, sometimes these increases are on purpose. One note that I didn't make it on this slide, my apology, was the decrease in specialty spend that was seen in 2023 for PEB, but this decrease was down to a specialty spend to 68.1%, which is quite large of specialty spend for PEB. So we know that specialty costs are rising. And when there's such a focus on the amount of specialty medications and costs that members are needing these days, the amount of specialty products that come to the market, our preferred specialty pharmacy strategy is it's crucial. And with that, we have our members taking specialty medications to support our exclusive specialty pharmacy through Arden Health. We have access that enhances clinical support without any restriction in time, so members can call in and have some support from the pharmacy 24/7. And members within the PEB population are taking advantage of that today. I wanted to highlight this because one of the questions posed by Mercer was, how are we really having access to pharmacy and helping the pharmacies really start members with new prescriptions and having that interaction. And when we look at where is the bulk of the time, the money, the spend, it's in the specialty space. And these are the complex medications and complex conditions that members are dealing with. A lot of the volume is in the traditional space. The generics is the highest volume of drugs dispensed, but the specialty is in the complex conditions. There were a few slides I did not include just for the time allotment within the presentation, and I think I might drop them in here just so you can see them. But it highlights that our specialty pharmacy, Arden, has had some really great results from the satisfaction survey. They participated in a national third-party patient satisfaction survey in 2023, and it resulted in an overall satisfaction rating of 98.7%, which exceeded pharmacy benchmarks. And they know that there's such importance of tailoring their connection with each individual member and throughout their journey, really to ensure that members' questions, meeting them in the middle or wherever they are in their journey so they can see success. So with each encounter, Arden evaluates how patients are doing. It creates opportunities for the pharmacist to intervene in real time. And in fact, in Arden's book of business, they have found that a pharmacist will intervene for every 4 prescriptions filled from a specialty perspective. So though we are not a closed system like Kaiser, so we don't have, the providers sitting at this system and having the patient in front of them, writing the prescription, seeing the fill history. We have a partner like Arden who is having those monthly calls and having those conversations about specific side effects, questions about if the medications are working properly, and really be an extension of our care team and really taking care of the PEB members who are utilizing specialty medications. So I just wanted to kind of mention on what MODA has done in this space to help the PEB members really have time with the pharmacies on their critical prescriptions and really being supported along the way. I also have some notes here about trend in 2023. I don't think there's anything too exciting. You've heard it from Sarah regarding the use of GLP-1 agents in the traditional space, increasing in utilization, specifically from Ozempic. We can talk about the strategies we have in place to ensure that the use is for the FDA-approved indications of type 2 diabetes, but I don't want to belabor the point. Also, some increases in certain specialty products that some lose patent protection that I'll have a slide on, and I think that's very exciting. And then overall, our specialty scripts per volume have increased. So just another reminder of why this space is so important is really this is the pipeline. If we want to move to the next slide. Here, we will talk a little bit about the biosimilar strategy. We've heard the good news about the Humira transition. This was the #1 selling specialty medication, well, the #1 selling, the highest rebated drug within the market landscape. We were highly anticipating this patent loss to come to fruition, and it did. There's a lot of strategy and conversation that our MODA industry relations team has when there are pipeline changes with patent loss, whether it's a traditional drug or a specialty drug. And so we had a lot of preemptive studies of the biosimilar agents coming to market, reviews of those studies, as well as conversations about lowest net costs with the multiple manufacturers that were gearing up to produce the biosimilars to Humira. This wasn't something that happened one day and the new biosimilars came to market and we started looking at it. This was something that 6 months, 8 months in advance, we really started strategizing about. And as we discuss it with the industry partners, different things evolve and opportunities evolve. We always look at a biosimilar or generic first strategy, but really want to have our ducks in a row. And what happened here with Humira, multiple manufacturers were releasing their products in around the same time frame. So there's a lot of different options that Sarah went through earlier. People could keep the Humira brand on the formulary and have a rebate for the brand, or they can have the brand on the formulary with a biosimilar option, or they can remove the brand from the formulary and have different biosimilar options. Well, MODA was one of the first in the nation we were an early adopter of removing the brand Humira from the formulary, and because we have a high performance formulary, which can be considered a closed formulary, that means moving the brand Humira off formulary, so it's no longer available on the formulary. And we had a few options of biosimilars available, which was our strategy. This happened pretty soon when these biosimilars launched. And one of the concerns within the marketplace was really how members were going to feel about no longer taking this brand name Humira. Well, we've had a lot of experience in the past with specialty agents losing patent protection, whether it's generic Gleevit that came out many years ago or other biosimilars. And so we've had really good experience with communication with the provider community, with the member community prior to these launches happening. and our great relationship with Arden, the specialty pharmacy, to really, in those touch points with members leading up to the launch, having those conversations, setting expectations about what's to happen. And so when the time came to change products, letters were sent, members were prepared, we saw an adoption rate of 98.8%. So Representative knows there always is, a pathway for formulary exceptions to occur. There's always an exception to no rule, but 98.8% of members transferred to the preferred biosimilars, which is amazing. That generated a plan savings for PEB members of $385,000. But, looking at preemptive 2004 numbers, the shift to biosimilar products, it looks amazing of what this is doing for the PEB plan. So teaser there, more to come, but this was just an extraordinary event that happened. We also made sure to update other products, brand products used to treat similar conditions, like Sarah had mentioned before, Skyrizi and Rinvoq, to ensure that members are now utilizing our preferred agent, the Humira biosimilars, before they're getting these brand agents that don't have a patent loss soon. So, this is when we are looking at strategies, it's a whole therapeutic class management strategy. So, of course, we're excited to look at the pipeline for other areas coming up. We have Actemra and its biosimilar Tyenne that's coming in 2024. This is an interesting space, but I won't spend all of our time talking about the biosimilar strategies. Stelara is coming in 2025. So this will be similar to Humira, where there'll be multiple biosimilars released at once. And so this, like Humira, will be a timing strategy. And this is also something that we've started having many conversations with the industry for many, many months, because again, the early adopter on strategy is going to be very important to have a clear, concise message campaign with members on what our plan is, and to have people, transitioned successfully and really get to work and have any sort of plan savings start right away. And I'll talk about what that also means from a member when I talk about specialty generic pricing, another question that was asked by Mercer. Xolair, we look forward to in 2025. So I won't spend all my time talking here. I could, but instead we'll move on. And I invite you to interrupt me. We were asked also to address access to medications across Oregon. And this is a space that's been very close to MODA. So I appreciate the question. There was a comment about pharmacy deserts. This is a very tiny map of Oregon was put here. This was borrowed from ORH. It's a defined urban, rural, and frontier areas. It's a heat map, so something that you might have seen before. But with MODA serving PEB members throughout the state, OWA members throughout the state, we have our Eastern Oregon CCO that's on the right side of the state. This access to pharmacies is something that we strive and talk about every single day. It's very important. So when we have a limited network where we don't have CVS within the network, we always are very careful to ensure that there is another pharmacy within X amount of miles available for someone who does have that acute prescription for an antibiotic, so they are not left without any option. We even look at 24-hour pharmacies, etc. So all of those are on the top of our brain when we're making updates and changes to our network. But I wanted to talk specifically about, I just lost my notes, my apologies, the critical access pharmacies. So this concept was established in 2009 by the Oregon Health Authority. Oh, thank you, Emily. In connection with the OPDP, which is a part of ArrayRx. And again, the MODA managing PEB members, together we are a part of the ArrayRx network. And so I just want to keep emphasizing that the work that ArrayRx does, PEB is a part of that work, along with states in Washington and, other states. So together, pooling the PEB lives with other lives within states, I think is a really great benefit to PEB members, because it's not just, the few, it's the many. So the critical access pharmacy was defined by geography-based definition of a 10-mile radius. You see here the goal was to address access to medications within Oregon and offer an appropriate in-network reimbursement rates, providing fair market value to remain open and ensure access is available to members. This is a conversation that continues to be crucial as we're talking about mergers and closures of pharmacy. We work very closely with OHA, and we really are concerned about how our members across the state have access. Certainly there's mail order pharmacies, and that's very important. And the PEB members with their benefits have an incentive to fill up mail order. It's 2.5 co-payments for a 90-day supply. We certainly can look at what it might look like within the 3.4%, benefits to offer a 2-month copay for a 90-day supply. But we really are passionate about caps and are involved in the continued conversation with the state. So the Administrative Rules Advisory Committee of 2024 amended the rules so we can redefine caps, and we really wanted to ensure that we are considering tribal populations, high poverty areas, frontier counties, and clinical services. The program was expanded to project access, promote health equity, and access to clinical service. So the result of this was we expanded critical access pharmacies from 21 to 59 in 2023. And that serves PEB members, again, across the state, including rural and frontier areas. So I think this is really important work when we're talking about access to medications across Oregon. On the next slide, we'll bounce to the question about strategies to help PEB plan and members receiving the best pricing for generic specialty drugs. So better guarantees, this, talking about guarantees really isn't my clinical forte of saying guarantees, but I like to boil it down to look at when we talk about better guarantees, that really just means better pricing and a better cost control. And so we, as ArrayRx, conducts an annual independent benchmarking of all of our drug pricing that PEB, of course, is included in and benefits from. So this benchmarking provides an aggregate pharmacy reimbursement rate guarantee. So it's on an average wholesale price, AWP price, minus a specific percent. And what it does every year is it ensures competitiveness within the market, and it adjusts drug pricing to remain market competitive. And so it's a third party that does this. We benchmark our pricing each year, again, by that third party. And if it's found that we are not competitive in pricing, we make adjustments. So an example is in 2023, there was a recommendation from this benchmarking study that we should create a distinct differential between our specialty brand and our specialty generic guarantee. And so we took action and we implemented a new guarantees to be effective 1/1/2024. And so we set a new guarantee for generic specialty pricing, which gets to the question that Mercer was asking. So the results for the first 6 months of 2024, ArrayRx has performed overall better in this space of the annual generic guarantee, and PEB themselves have been performing better as well because PEB benefits from the ArrayRx network through MODA. So I think when we talk about RFPs, I mean, all of these are spaces that I think we're excited to provide you more information about. It's really hard in a 30-minute presentation to get in to all of those details and really show it, but I hope it makes sense and it tracks, because this really is where the ArrayRx program, and we talk about transparency and what does that mean and how transparent is transparent, but ArrayRx, really that's what we've been doing for many years. And so From a formulary perspective, generic specialty tier is low cost to members. From a benefit design, we really favor generic products over brand products. And so, this incentivizes members as well as all the other coordination that we have in place from a formulary design of directing members to specialty generics and, having such a collaborative network available with our specialty pharmacy, our relationships with the providers, et cetera. Okay. On the next slide, I wanted to touch on GLP-1 agents, and I know we've heard earlier about these agents. What I really wanted to hit on is a reminder that the Ozempics, those that are approved for type 2 diabetes, we still ensure that a diabetes diagnosis is provided when these are filled, and we have conducted an audit to ensure that the diagnoses that are provided is actually, true in nature, and that has shown that it is working as intended. There has been a lot of movement in this space. For instance, Wegovy, this medication had the indication for chronic weight management, so it has not been covered. However, it recently gained the FDA-approved indication in major adverse cardiovascular events, and that is obviously not in the chronic weight management space. And so this creates the allowance of adding Wegovy to our formulary for coverage. And it's very important that when this happens, we are very intentional with our criteria coverage and ensuring that those who are requesting coverage for Wegovy are meeting the FDA-approved indications and studies for the MACE indication, which we have done and taken to our P&T committee, et cetera. But we've also are expecting to have a new FDA approval for a GLP product for obstructive sleep apnea. And, we are seeing that there's a lot of secondary benefits from using these products that could be secondary to weight loss. So obstructive sleep apnea, oftentimes when there's a reduction in weight, it reduces the events of obstructive sleep apnea mechanically with the palate of the mouth. So clinically, I expect that there's going to be more and more studies from GLP-1 manufacturers for these kind of secondary indications that the FDA will be asked to approve. And so we are monitoring that, and we are ensuring that we are, working with our actuary team and wanting to stay ahead of what that might mean from a financial perspective, and also really vetting that to ensure that these are needed from a clinical perspective, or are they secondary to weight loss, or just kind of what this means. And so this is a pipeline that I just wanted to bring to your attention. We did have continued conversations with industry. So part of the exploration that we did collectively as the multiple plans and with Mercer last year was having conversations about affordability of GLP-1s in the space of chronic weight management. And one of the things we learned was at that time, though the FDA approved label was chronic weight management, in addition to lifestyle management techniques like like exercise and dietary. However, any rebates offered by industry would not allow us to have the lifestyle management techniques, like requiring the the exercise and the dietary restrictions. We continue to have many conversations, and they finally are willing to budge on that. So our tenacious efforts from an industry department, industry relations department, has finally brought us to this point. This is just breaking news in the past week or two. So I think that, we have a little bit movement there, more conversations to be had. This space is always changing. Sorry for my bobbling there. My last slide is a slide to ask for questions. I think I have 2 more minutes. I just wanted to touch on approaches to polypharmacy and deprescribing in conjunction with prescribing with the physicians. We've talked over the years about the programs that we have in place in regards to opioid prescribing and assessments. And we have a program that does look at opioid utilization and has an outreach aspect to providers. We also do each year 4 medication use evaluations that often touch on these types of polypharmacy and deprescribing. One we did this year that was a repeat from 5 years ago was benzodiazepine use with opioids. And we had 20% of a movement within the PEBB population. So a concomitant use of opioids and benzodiazepines, which could be a high risk of overdose or death. Also in gaps in medications for chronic management, how we engage with prescribers, we have adherence monitoring reports and really alerting prescribers, what is the fill history with some members and making them aware that they might not be filling within an adherence pattern. And then again, with the medication use evaluations, really identifying those gaps. We also have some different programs with statin use in persons with diabetes or with cardiovascular disease that really helps identify members with diabetes or cardiovascular disease who could benefit from a statin following guideline recommendations. So touching briefly on that, just in the interest of time, and Emily, I see you asked, can you remind me of which law the 2004 RAC is associated with, that amended rules 2024 RAC? I do believe we have that. I think Robert Judge is on the call and probably can dip it in the chat because he knows. And I think that's my time.
Right. Thank you, Katie.
Thank you.
So it sounds like we'll have Emily's question answered in the chat. And we are going to push the agenda by 5 minutes out to give Providence their full 30 minutes. And my understanding is we don't have public comment today. So we'll finish up after Providence does their presentation. So I'm going to hand it over to Gina and Laurel.
Great. Thank you so much. And I appreciate everybody's attention to this matter as well. And I'm fully aware I'm also keeping you from lunch and other things of the day. So what I want to do is just briefly tell you that, as a health plan and part of an integrated delivery system, we really do feel very, very strongly about the role of pharmacy services. Next slide. And as most of you are very aware, we do have our promise, which is know me, care for me, and ease my way. And what that really means to us, though, is how do we care for our members? How do we take care of them and make this easier? We know that healthcare is complex. We know it's expensive. And as you've heard, the cost of the pharmaceuticals plays a really significant role in this. Next slide. But at PHP, I think the one takeaway, and you're going to hear this from Gina too, the one takeaway I really want to leave you with is that we don't see pharmacy in isolation. The pharmacy spend is due to the diagnoses that the members have, both medical and behavioral health. And the quality of their care, the conditions of their care, the acuteness of it is very, very tied in many times to health equity, to access, and directly related to quality as well. So as we look at pharmacy, this is really integrated and woven into how we take care of our members at Providence Health Plan. And the barriers that our members are having, if they have them, in accessing medical care is going to be the same for behavioral health and for pharmacy space. So knowing this and knowing we need to take care of that entire member as well as their family members, we actively engage with our care management to assist our members with pharmacy challenges as well as their medical challenges. Again, these are one and the same in many, many instances. So we engage with our prescribing physicians. That can be at a care management level, that can be at our pharmacist level, and that can be at a medical director level. So myself and our other medical directors to really assist our members who are having gaps in medical and behavioral health care and pharmacy access issues like we have discussed earlier today. So just giving you that overall broad that we absolutely want to take care of the members, help them, make it easier for them to access medical care and the pharmaceuticals that go along with that medical care and that behavioral health care. So I'm going to turn this over to Dr. Gina Kohlraub, our Clinical Director of Pharmacy, and she's going to discuss these issues with you in more detail. Thanks again for your time. Gina?
Thank you, Dr. Soot. So today we're going to be talking about a few things. Number one, we are listening to you. We are aligning our pharmacy strategies based on previous pharmacy discussions together. And we have been partnering with you for many years, and we want to continue to grow really in this exciting time of pharmacy with new drugs in the pipeline and really navigating the complexities of it all. So if you want to go to the next slide. We have heard in our previous pharmacy discussions together some of the critical insights you have identified that are important, like health equity, access to medications, and that important pharmacist provider member payer connection and those touch points along the way. And we have made progress in these areas and continue to improve. So starting first with health equity. And I want to particularly give you an example related to tribal and rural communities and really the care for all persons. So we support rural pharmacies, for example, by reimbursing them at higher rates, and this is to help support lights on, doors open. Access to medications, we have an expansive pharmacy network designed around our own in-house pharmacy team. We also have mail order options that might be convenient and flexible for PEB members to choose. And we have 24/7 pharmacists on-call support for urgent requests. And this is really to support those frontline pharmacists and PEB members at the site of pharmacy. So I'll just give you a quick example. Last year, I was a pharmacist on call for PHP members, and I had supported some members who had experienced fires and had lost their homes. So it was really a vulnerable and a critical time, really to support members, easing their way in order to ensure there was no barriers to access their medications. And that pharmacist provider member payer connection, which is really the connection points that could lead to better health outcomes. So supporting pharmacists, those frontline pharmacists in the state of Oregon, and really making sure that we can reimburse and support pharmacists to practice in their full scope of care. So that means pharmacists that can prescribe things like oral contraceptives when needed, administer vaccines, treat and test for COVID, and various other things, again, along the scope of their practice point to support them. We also have that provider piece that is ever important. So really providing education. We work closely with the Oregon Board of Pharmacy. So one example is working with the Oregon Board of Pharmacy to provide continuing education credit around opioid education. So this is a particular area that is very important in terms of polypharmacy, prescribing and deprescribing medications around this critical area of opioid management as well as pain management. We also leverage technology. So I'll share with you in a few slides about our point solutions to help members. And we do this in multiple ways. We work with the physicians, so we have a real-time benefit tool to help providers, and really the ability to pull in the benefit for the PEB members to see right at point of prescribing. We also have RX Savings Solutions, which is a price shopping tool available starting January 1st, 2025. I'll talk a little bit more again about that in a moment, but I just want to mention that it also has the ability to allow for engagement campaigns around chronic conditions. So things like heart disease or medication adherence. We also support PEB members in many ways, including having our pharmacists, our Providence Health Plan pharmacists, complete comprehensive medication reviews for PEB members. So we've had multiple patients in 2024 participate in what we call CMR reviews. And that is really just having our pharmacists look at those complete medication lists. And that is not just prescription medications. It includes herbal supplements. It includes over-the-counter self-reported medications, looking at the whole picture to provide chronic disease state education, reinforcing medication adherence, as well as identifying drug therapy problems, and then quickly reaching out to the provider prescribers when needed. Dr. Soot spoke about case managers and really that important interaction point. And one of the ways we believe we can help the frontline providers the most is by ensuring that PEB members have the ability to pick up their prescriptions. So this means access. This means education around medication adherence, which is important really to support those providers. So we continue to listen and deliver on our promise of know me, care for me, and ease my way. If you want to go to the next slide, please. The pharmacy strategies are really crafted around impact for PEB members. So starting first with honest pricing. Through our honest pricing, we are ensuring that PEB as well as PEB members receive the best possible pricing and rolling out strategies to manage cost, including maximizing rebates. At the same time, we are focused on quality access to the needed medications. We also have a comprehensive clinical management strategy, really designed around optimizing formulary to ensure that clinical indicators, as they change, PEBS medications follow leading edge guidance. And finally, we have a really focused point on outstanding member experience and medical integration, really ensuring medication, again, access, people understand their medications, and we are constantly monitoring for gaps in care. Because our strategies deliver on your needs, we project $17 million in savings for PEB in 2024, which is an additional $2.4 million from 2023. At the same time, we're focused on that member experience. So I will walk you through that in the rest of our time today. If you want to go to the next slide. And starting with honest pricing, as Sarah discussed earlier, there has been scrutiny on PBMs really in 2024, particularly this summer. The Federal Trade Commission has released reports on investigating PBMs. The state of Oregon has been tightening rules. There has been lawsuits occurring in many cases. And traditional PBMs really negotiate prices and rebates on the behalf of the clients, but they might retain the savings. So I just want to point out that Providence Health Plan passes on the full value of rebates and discounts to provide clear visibility into pricing and cost savings. This strategy is designed really for PEB plan as well as PEB members to receive the best prices on the medications, but I really want to call your attention specifically to generic specialty drugs. So I have a slide on that in a minute and can really share how that really has an impact when we're looking at the whole picture for PEB. We want to go to the next slide. We are also driving to the lowest net cost, ensuring best prices as well as the comprehensive clinical programs and tools in place. At the same time, this is occurring without changing pharmacy benefits. So the last time pharmacy retail copays changed was in 2012. So that's 12 years ago. So ensuring that PEB members have rich benefits and at the same time driving to the lowest net cost with trends. If you want to go to the next slide. So I want to share with you some examples of our comprehensive clinical pharmacy program now, and I'll spend a little more time on this slide specifically discussing cost savings, medication access, and really, again, back to that supporting the frontline pharmacists and providers piece. So we have strong utilization management in place, and that's really ensuring appropriate, cost-effective, safe medications. The formulary is designed around that generic first therapy optimization. One of the things that we do different in terms of prior authorizations is that we have tools in place really to help us with difficult cases. So I'll give you an example. We have an oncologist provider who supports these difficult case reviews for prior authorization to ensure that we get it right the first time. We also have a care management team that completes med reconciliation, or really looking at those medication lists to assess for all enrolled members. And that is often some of the most complex high need members. So we work with case management. They often will do referrals, and we have a shared medical management platform really that can conference in pharmacy, the member, really the holistic team to provide support. And again, it's going back to those looking at that medication list in terms of over-the-counter medications, herbal, supplement, disease state management, reinforcing, and focused on medication adherence. We also have care coordination and home health. This involves coordinating with prescribing physicians and pharmacies to guarantee the accurate prescription of medications and the most cost-effective, price-matched, and most affordable option. Our care management team hosts weekly rounds facilitated by our medical directors, including, again, our pharmacists on staff, other providers, really anyone a part of the team that can really gather information to help prevent and address members' avoidable healthcare utilizations. We think about health disparities, access to care, transportation, transition needs. With that, we also have transitions of care in place with our care management team really assisting members and those really high touch points or times of transition to meet the members' needs in terms of all of their needs, but that also means pharmacy needs and their prescriptions as well. And then we have thoughtful transitions to generics and biosimilars. So through our rebate negotiations, we were able to increase rebates for Humira, and we have biosimilars in parity on our formulary, really to ensure that the net cost for PEBB is at the lowest possible cost, and we also allow for choice for PEBB members. We manage the class of therapy, so that means we do receive rebates on other medications within the class. And I think this is a really important but a thoughtful decision based on our physician and therapeutics committee and a lot of different factors in terms of what we choose for formulary. For example, we know that not all members at all times can be on Humira, and there is sometimes patients need to switch medications. So, for example, Skyrizi for psoriasis has shown lower long-term costs associated with getting on highly effective therapy sooner. So it's really a balance, and it's something that we really carefully consider when we're choosing our formulary. We have had biosimilar strategies where we have moved fully to particular biosims, for example, Remicade, which is a medical medication. And that one is really used for many indications as well. So it just depends, but we are focused on the lowest net cost for PEB members. We believe with the upcoming biosimilar strategy for Stelara that by January of 2025, there will likely be at least 2 biosimilars expected. So we're really excited as we prepare for this strategy as well. And we continue to work with manufacturers and rebates, being nimble to maximize savings for PEB. We also have our specialty drug management team in place, really monitoring for these high cost medications. They're often low utilization, but really impactful because they're often rare diseases, very vulnerable members, and ensuring that they have access to these critical medications. So our specialty team, prioritizes timely medication delivery for members, guaranteeing uninterrupted access to necessary treatment. In 2024, between January through the end of May, approximately $450,000 has been saved by just looking at these optimizations in the specialty arena. If you want to go to the next slide. I also want to touch on the site of care, which was really a robust, high-touch site of care program to drive to the lowest net cost, ensuring that those infusion medications are administered at cost-effective sites. So $432,000 has been saved year to date for PEB members related to our site of care program. It's not a stagnant approach, it's constantly evolving. It involves care outside of the hospital. So we have partnerships with nationwide home infusion options that are convenient and flexible. We have a white glove approach to ensure that it makes sense for the members to move to those sites. We have connections to our delivery system. So we have access to 39 facilities in Oregon and Washington for standalone infusion centers, also providers' offices and clinics. And it's the majority of medications that really are administered via the infusions outside of the hospital. So we continue to look at this with oncology medications as an important area, as these medications are now often considered or continued in certain treatment pathways more often than others. So it's really important to adapt. And I'll just give you a quick example here of one infusion center charging $3.63 per unit for the same drug. Another center charged $159.94 per unit. So it's important, really to find these site neutral sites have bested in market rates, but also to focus on supporting access to medications at the same time. If you want to go to the next slide, I also want to talk about the digital tools we have in place. They're the point solutions really to improve the member experience, but also to ease the way for providers and those frontline pharmacists. So we have had real-time benefit tool in place since 2017, which is an electronic prescription tool at the point of prescribing for PEB members. So it pulls in PEB member specific benefits, really to ease the way for providers to be able to select the most cost-effective yet clinically important medication for members. We also have electronic tools like electronic PA authorizations to help with polypharmacy and really streamlining prescribing. Starting in January of 2025, we're really excited about the ability to have the addition of RX Savings Solution, which is a price shopping tool for members. This also has the ability to really focus on some of those gaps in adherence for chronic conditions. RX Savings Solutions in partnership has the ability to do targeted campaigns around medication adherence, around chronic conditions like heart disease, diabetes, and can provide cost-saving opportunities. So if you want to go to the next slide. I also want to talk about the importance of integration. I know this was touched on earlier as well, and really our approach to partner closely with our medical partners, but also with our delivery systems. So really partnering closely with healthcare providers and medical facilities, and this can really provide benefits to PEB members. We offer PEB clinical case reviews, as I mentioned before. We also can empower PEB members really to navigate their care and boosting engagement as well as adherence to their medications. We also have the ability to implement targeted clinical specialty programs. So, for example, multiple sclerosis, which has a high rate kind of in the Northwest, Pacific Northwest area, and looking at as disease states change and adapting to new medications that are available, really focusing on those high impact targeted areas. So I just wanted to share a few outcomes with PEB. There was a few PEB members that were really these case examples of the benefits of really working together and those connection points I spoke about earlier. But our specialty team has worked really with providers, with delivery systems, and has really looked at optimization. And here is an example of a member who had a tablet strength optimized, and it saved PEB $88,000 a year. The member copay remained at $0. And then a member who switched to a generic anti-cancer medication, which saved the plan $61,000 per year. So if you want to go to the next slide. Now, just switching topics quickly, going into really diabetes and the important use of GLP-1 medications for PEB members and the potential reduction in total healthcare costs from these agents. So we identified claim data for PEB members with diabetes, and 65% of the members that we had claims for had hemoglobin A1C measurement levels available via these claims. Hemoglobin A1C is that blood sugar measurement, and it's approximately over 3 months, but it gives a picture or kind of a glimpse into how well the blood sugar is controlled for members. In 2023, looking at the data, we see that the hemoglobin A1C reduced more for diabetic members or those members with type 2 diabetes on GLP-1s than diabetic members that did not use these medications. And when we extrapolate this information, even though it is limited and it is based on claims data, we do know that the National Institute of Health, or the NIH, does share the relationship between hemoglobin A1C, or again, that blood sugar level over time, and healthcare costs among patients with type 2 diabetes, that the reduction seen with these PEB members could result in a 1% reduction in total healthcare costs for PEB. But this isn't the only story. We have Virta in place. We know that this is a holistic approach to care. So for diabetes management, Virta is able to also improve hemoglobin A1C, weight change, promote blood sugar management, and to really help members get off these medications when they are stable. If you want to go to the next slide, I'm going to contrast that now with the providence and the strategies around GLP-1 specifically for weight loss. This is an important and an evolving dynamic topic. Currently, we have a prior authorization on place to ensure that members are receiving GLP-1s for diabetes. But we are exploring many things, as we know this is very important for coverage for the future of PEB, like expansions of lifestyle management programs to support long-term sustainability. So we know that food as medicine, exercise and maintaining muscle mass, and really that approach to whole person care is really all the factors we want to look at for these programs as well. We're exploring social determinants of health in terms of access and affordability, and really exerting influence on manufacturers to put in cost controls and create innovative ways to make these drugs more accessible to underserved communities. So I'll share with you that we are working with a manufacturer specifically to negotiate a pilot to really focus on an underserved community, really to increase accessibility for those members that we know have limited access to these medications. You want to go to the next slide? And as I mentioned earlier, talking about really the PBM and the importance of our role, what we can do is really focus on driving our formulary to the lowest cost options like generic specialty medications. And this is really significant when we look at the top generic specialty medications currently filled through PEB at Providence. And what we find is that $911,000 is annually saved on making these switches from their branded products to the generic. And it can be 10 times less expensive than the brand alternatives in some cases. We MAC all generic drugs. That means we have maximum allowable costs on our generics to drive to the lowest prices. We also price compare. So we looked at disruptors like Mark Cuban, discount vendors. We use consultant data to ensure that we're getting the best in-class prices for PEB. All right, if you want to go to the next slide. I want to walk away with you knowing that we are taking action, seeing results, our pharmacy cost trends, our clinical programs, our technological tools, and are committed to driving further our results in the future. Thank you for your time today.
Great, thank you so much. Any last questions for Providence? All right, and I don't believe we have any public comment today. Is that right, Rose?
Right, you'd have no public comment.
Okay. So appreciate all of the presentations from our carriers. Thank you so much. And really appreciate the discussion that you led, Sarah, our Mercer team, doing lots of work around pharmaceuticals so that we can be ready for a really comprehensive RFP proposal that we're going to put out. Any announcements, Ollie, that need to be shared with the board?
No, just thanks for your flexibility. We rescheduled the retreat a week earlier, and I think it's for November 12th. So we got that on the calendar and appreciate people being willing to move that.
Right. Thanks. Thanks, Ollie. I will formally end our meeting today. Thanks, everyone.
Thank you.
Thank you.
Thank you.